Good evening, respected professor and my dear students. I welcome you all to today's session of BNB academic activities on RAISA on Webex platform. Today we have exam topics like instruments, equipments, drugs and machines, and X-rays and investigations, other investigations. I hope all the students are well aware that the practical examination is every time changing and new topics are being introduced every time. Last time, one of our student had difficulties in defibrillation and ACLS. These are the basic things, and the ward rounds also they are including new topics. So I request Professor to kindly cover all those new aspects of so that our students can pop up with the examinations, practical examinations that are likely to be conducted in 3 weeks' time. Thank you, sir. Over to students and professors. Thank you, sir.
So it's okay if I start with ABG, PFT and ethnography.
Yes, sir.
Yes, sir.
Yes, sir.
Is screen visible?
Yes, sir.
Yes, sir.
Right. So this is one ABG report given from one machine, a typical arterial blood gas analysis report. This is rapid system, a shorter version of the same ABG report. And this is another presentation. So if such reports are given in your hand and if you are asked to interpret, how will you proceed? I
First
want
one
this
is
to be more of interactive session rather than lecture type.
Yes, sir.
So what is the first thing you will do once the report is given to you?
Patient identification, name, sample.
Yes, very good.
and calculated
First,
values.
make sure that it is a report of the patient for whom you have done the test. So go through all the identifications. So in this first report, if you see, it is all given: patient ID, patient last name, sex, sample taken, whether it is arterial or venous, FiO2, temperature. These are all important parameters that have to be given. Whereas in these reports, you don't find all this. These are all shortened versions for ward use. Once the patient has been repeatedly being tested, it is okay that they don't provide that. But first time when the report is given, it's always better that you have to make sure that the report is the concerned patient's report and not somebody else's. And it is a diagnostic tool. What are all the things you can diagnose using the AP?
This is text in
Already the answer is given here.
Acidosis.
What are all the values you will get once you do an ABG?
pH, sir.
Huh? You can eliminate
pH,
whatever you have seen in
HB.
the earlier report, such as how it is being presented. Always, what is the first thing it will be presented? pH will be there, isn't it?
pH, sir. Yes, sir.
Then PCO2,
PCO2 and PO2,
PO2,
O2,
bicarb,
and
bicarb.
calculated bicarbonate,
electrolytes.
and sodium, potassium, electrolytes.
Bicarb will be followed always by base excess. Okay?
Sir.
You will always find that both of them will be clubbed together. Then you will find that there will be electrolyte values. Why electrolytes are given along with the AB?
To calculate the anion gap, sir.
Calculate the anion. What is the importance of anion gap?
And we diagnose any high anion gap or normal anion gap. So if it is high anion gap, we could
What is the first definition of anion gas and what is the importance?
of anion gap is unmeasured anions and cations in the plasma set. A difference between the anions and cations.
Is the difference between the
Anions and
unmeasured
cations.
Cations. And the unmeasured anions.
Okay. But when you calculate it, which will be higher? Positively charged ions or negatively charged ions?
Cations. Cations.
Cations will be higher. So what are all the unmeasured anions?
Albumin, organic acid,
Hmm.
phosphate, sulfate.
Phosphates. So these are the things which are not measured. Okay? That is the thing that we have to know. So these are the values that will be given. And supposing they ask you the name of the person who introduced this ABG, who was the person who was responsible for introducing this concept of analyzing the arterial blood gas sample.
John Mendel.
John Wendell Severinghurst. Okay? He was the man who, in collaboration with a company called Astrup, he was the one who was responsible. He made the CO2 electrode also to measure the values of carbon dioxide in the arterial blood sample. He was the man who was responsible for introducing the method of arterial blood gas analysis. What are the values that are actually measured using blood gas apparatus? What are all the values that are calculated in the report that is given?
pH, PO2, PCO2 are measured. And
Measured.
electrolyte.
Very good. The other things are all calculated from that. He is the person who was pioneer in doing this machine. This is the original machine that was given by him. We use this formula for that, calculating the pH. These are all Clark, Wendell Clark was, what was his contribution? Clark's oxygen electrode.
O2 electrode.
Oxygen analyzer.
Severinghurst was responsible for carbon dioxide measurement and Clark was responsible for oxygen measurement. And this man Sorensen is the person who coined the term pH. What is the meaning of pH?
Power of hydrogen.
Power of hydrogen. Also, Poisson's hydrogen in various languages it's all given that. So these are the measured values. These are the calculated values. Saturation factors. And Sorensen in 1909 gave that pH. Always pH should be written with a small p and a capital H. And it is in French it is called puissance for P and potency or potence for German, potence in Danish language also. So Sorensen is a Danish fellow. So that is how we give the concept of pH. And collection of blood sample is very, very important. Commonly, which arteries we prefer, radial artery. What is the reason for selecting the radial artery?
Superficial, collateral circulation.
Very
So
superficial, very good, easily accessible. And then
Presence of collateral circulation.
Ulnar collateral.
Any other reason? Even if there is a bleeding, is it easy to compress that and prevent a hematoma, or it is difficult compared to femoral?
Easier to compress.
Yeah,
Compress.
easier to compress and prevent a huge hematoma formation. Okay. So, and what are the reasons for wrong value or reporting to be done? What are all the iatrogenic errors by which ABG code can be faulty?
One is wrong labeling, sir. They can
Wrong labeling.
wrong patients also
Air.
can be entered.
Air. When you draw, there should be absolutely no air bubble in the syringe. Very good, number one. Any other?
At the transporting times,
This is
it's happening.
Anything with the collection. At the time of collection, there should be no air in the syringe. Anything else at the time of taking the sample
Without heparin, sir.
without
Anticoagulant.
heparin,
Yes,
then
sir.
it is clot.
The
Too
heparin
much of
refill
heparin.
is
Too
too
much
much.
of heparin should not be there. Okay,
Yes,
so there
yes.
should be very minimal heparin to prevent the clotting, and excess heparin, excess or a presence of air bubble. How will the result will get altered? Supposing
It
you
will
have a sample with the air bubble, then what will be the result? If you have too much of heparin, what will be the result? Which value will be affected by these mistakes?
oxygen, sir.
PO2,
Oxygen.
PO2.
Yes, if you have air bubble, it will show excess oxygen, even in hypoxia. And if you have excess heparin, pH will be altered. Okay, it will show more acidity. Transport time is very important, and proper preservation of the sample. It is the second step where mistake can happen. And the third step where mistakes can happen is faulty administration of the sample into the machine. Okay? And machine errors. The machine has not been properly calibrated, or if the machine's membrane has been not properly changed, then all those things can make a mistake. Okay? So air bubble to be avoided. What is Allen's test? That also may be asked. What is the importance of Allen's test?
To check the collaterals of the
Check
circulation.
the collateral so that you don't produce any ischemia of the crystal limb. Okay? All of you know how to do that. And the technique of taking the sample. This is the air bubble that should not be there, and you should not get hurt. You immediately tap it after taking the sample. These are all the important things. Technical errors, excess heparin, only 0.5 ml should be taken. And it should be rinsed and it will let out all the excess one. So it will affect the values. Air bubble will increase the PO2 and decrease the PCO2. And WBC count, body temperature, all these things also can affect the values. So ABG machine, there are different types of ABG machine. I don't know how many of you have gone to the lab and seen how they do it. Nowadays, do we have bedside or point of care testing of ABG?
Yes, sir. In ICU, we are having, sir.
Yeah, you have that. Okay. Are you using this test or some other?
Yes, sir.
So this is a portable bedside machine. Earlier, it all used to be in the laboratory. So handheld method are there. Not going to the details. This is the sample how it will be fed, and immediately the results all come. And this is the basic internal circuits of the ABG machine. This is the handheld sample which you can easily see. The working principle. What are the normal range of values for ABG? What is the value for pH?
7.35 to 7.45.
7.35 to 7.45. Okay, what is the value for PCO2?
35 to
35 to
45 mm of
45
mercury.
millimeters of mercury.
35 to 45. What is the value for PO2? 75 to 100.
75 to 100.
High carb, 22 to
25.
22 to 26.
mid value is 20. Phase excess and deficit can be either +2 or -2. Saturation 95 to 100. At standard values of 21 to 24, standard bicarbonate value, PCO2 should be 40 at temperature 37. So total carbon dioxide, how do you calculate the total carbon dioxide? Bicarbonate is plus arterial carbon dioxide will be 22 to 33. So, and oxygen calculation, we both with arterial oxygen tension multiplied by 0.003 saturation multiplied by 1.34. What is this 1.34?
Toughness values.
Toughness constant.
Toughness constant and hemoglobin. Okay, so they may suddenly ask you about how to calculate the oxygen content and the total carbon dioxide. So remember these formulas. And these are all things which we can go for. Activity. So I'll just give you some examples of values for you to, and this delta gap is very important. What is the importance of delta gap? Which is the increase in anion ratio between the increase in anion gap and decrease in the bicarbonate. Okay? And this gives a picture of whether there is a combined acidosis and alkalosis. Sometimes you can have what is called multiple disorders or complex disorders. So always it will not be straightforward. In such cases, it will be useful to do the data gap. And all the compensation formulas you should know, and you should know when to apply them. And for metabolic acidosis, you have the Winter's formula to calculate the expected CO2. And for alkalosis, you have to find out the expected PaCO2 and the increase in bicarb. For respiratory acidosis, you must know the change in the bicarbonate or the value of bicarbonate that will happen. These are the compensation formulas that are to be learned before you go for your exams. And the steps in approach to ABG. Can anyone describe what are all the 6 steps that you have to do before you interpret an ABG?
First is demographics of the patient, sir.
Okay, right. Then?
Next, whether it is it authentic or not.
Okay, how do you find out what is the term used for that? Whether
Internal
it is authentic?
consistency.
Internal consistency, very good. How to find out the internal consistency? What is the formula to be used? (24) into PCO2 by bicarbonate value. That is the formula you have to use to find out the internal consistency. 24 multiplied by PaCO2 divided by bicarbonate. So measured bicarbonate. That will give you that. But after doing these two, how do you approach the interpretation?
Look at the pH.
Acidic or alkaline. Very good. Then
Whether it is respiratory or metabolic.
with the pH value, can you straight away go for respiratory or metabolic?
Primary disorder.
PCO.
No, only looking at the pH, is it possible to decide whether it is metabolic or respiratory?
No, sir.
You need to look at PCO2 and bicarbonate. Only you can definitely decide whether it is metabolic or respiratory. So pH will only tell you whether it is acidosis or alkalosis. Okay? So to find out whether it is a metabolic origin or respiratory, you have to check the values of PCO2 and bicarb. And along with that, whether there is any hypoxemia, you have to go for the right value of PO2. Okay, so that is the order: pH, PCO2, bicarb, and PO2. So that is the approach that which you go. So first step is to find out whether it is acidosis or alkalosis. Then whether it is of respiratory or metabolic using PCO2. And then if it is respiratory, whether it is acute or chronic, and any compensation. And if it is metabolic, anion gap automatically. And if the anion gap is tight, then you have to go for delta gap or gap. Okay, so these are all the 6 steps that you have to follow. And step 1 here, the pH is 7.18. Okay, so actually this is acidemia. Step 2, pH is low, PCO2 is also low. So probably this is a metabolic origin. So look at the bicarb. Bicarb is also very low. So this is why PCO2 is low here. What is the reason for such low PCO2? It's a compensation. So the patient is hyperventilating to wash out the PCO2 to bring back the acidotic pH to normal. Okay. So what should be the expected PCO2? You have to calculate here, and it should be Winter's formula 1.5 into multiplied by the bicarb which is measured, and the plus 8 plus or minus 2. So here the value of bicarb is 7.8. So multiply that, you get about 19.7. That is including the 8 and the 21.7. So patient is adequately compensating by washing out the carbon dioxide. On the contrary, even if this is about 35, will you consider it as normal? In case the value here instead of 21, if it is given as 35, will you consider it as a normal value or abnormal value here?
Abnormal, sir.
Abnormal. So how to find out? Why this formula helps to find out that even if 35, which is considered as a normal range in a healthy patient, in the presence of a severe metabolic acidosis, if the PCO2 is not reduced, then there is a combined element of respiratory acidosis with metabolic acidosis. Okay, so even if the value is given as 35, and by calculation, if you find it should actually only be 21, that means there is an element of metabolic and respiratory acidosis. That is where this Peters formula is very, very helpful to find out a combined uh, derangement of both metabolic and respiratory. And then go for anion gap because it is now become established that is a primary metabolic acidosis. So find out the anion gap. Anion gap is also, is it normal? 30.8?
Yes, sir.
30.8
No, sir. High.
Increased.
very, very high, isn't it? 12 to 16 is the normal gap. Here it is almost double. So for corrected with albumin also it becomes 36.5. So it's a high anion gap metabolic acidosis. Actually, we should do a delta gap value also, find out whether there is any occult alkalosis or not. And but here it will be confirmed that it's only a high anion gap metabolic acidosis with partial respiratory partial compensation because pH is not brought back to normal. If the pH has returned to normal by this washout of PCO2, then it is called fully compensated. As long as the pH remains in the acidotic state, it is called partial compensation. And this is the formula I told you to find out the internal consistency 24 multiplied by pH by bicarbonate. And can you take a venous blood sample instead of arterial blood sample? Will it correlate with arterial in case you have a patient in ICU and you don't have regular access or you don't want to do a on poking it, so there is no arterial line? And can you do the ABG assessment with the venous blood sample and will it correlate with the arterial blood sample?
Yes, sir. There are minor differences only, sir, between venous and arterial.
Venous and arterial. Which one will be the major change?
PCO2 we have to add. It will be
5.6
millimeters more in venous.
plus or minus
PCO2
5.
will be obviously low in venous sample. Okay, that is the only thing. All other things will be more or less equal. So I will just show this. The correlation between venous blood sample and arterial pH, there is a good correlation. PCO2 good correlation in normocapnia. Bicarb, there is a good correlation. Lactate dissociation above 2 millimoles, and base excess also there is a good correlation. The only thing which will not correlate well is CO2, PaO2. So that is the one which will not be. So for emergency purpose, you can always do a venous blood sample also and find out the values which will be more or less equal to arterial blood sample. Now, I'm giving you some examples for you to analyze. I'm giving just three values of pH, PaCO2 and bicarb. So can you make your interpretation quickly just for training purpose?
Respiratory alkalosis.
Respiratory alkalosis is partially compensated. Okay? Because bicarb is not gone up. If it is respiratory alkalosis, bicarb should also, what should happen to the bicarb? I mean, it should go down to reduce that. Because bicarb is also an alkali, isn't it? So that is not gone, and pH is also not brought back to normal. So what is this condition?
Metabolic acidosis.
Metabolic acidosis, uncompensated, because PCO2 has not gone down. Normal, it should be washed out. So I told you this is, even though this is normal range, it is not done any compensation.
Metabolic acidosis, but it's partially compensated.
Partially compensated, correct, because PCO2 is low, just 1 millimeter lower than the normal range. What about this?
Uncompensated metabolic alkalosis.
Uncompensated respiratory alkalosis. Actually, here PCO2 is low and pH is high. Okay, so bicarb is normal. So this is uncompensated respiratory alkalosis, not metabolic alkalosis. What about this?
Partially compensated metabolic alkalosis.
So its primary defect is metabolic alkalosis because pH is also on the alkalotic side. Bicarb is more than 24 and PCO2 should have been higher to compensate for that. So it is a primary metabolic alkalosis uncompensated. What about this?
Respiratory alkalosis with us.
Respiratory alkalosis. Here PCO2 is 48. How can it be respiratory alkalosis? PCO2 is 48. Is more than 45, isn't it? The compensated, partially compensated respiratory alkalosis, I mean metabolic alkalosis, because pH is on the alkalotic side, bicarb is also high, and to compensate for that, there is an accumulation of CO2 going on. So that is a partial compensation. The pH has come back to normal with a high PCO2 and a high bicarb, it is a fully compensated. So here it is a partially compensated metabolic alkalosis. What about this condition?
Uncompensated respiratory acidosis.
Acidosis. Okay. Because PCO2 is very high, pH is also acidotic, and bicarb is not fully compensating. So respiratory acidosis partially compensated. pH 7.55, PaCO2 47, bicarb 30.
Metabolic alkalosis.
Metabolic alkalosis.
Primary metabolic
Partially-
alkalosis partially
Partially
compensated.
compensated.
Partially
So now you have got the clue how to make. You get 7.20, CO2 49, bicarb 25.
Respiratory acidosis.
Respiratory
Respiratory
acidosis
acidosis
is
uncompensated.
uncompensated.
pH 7.30, CO2 36, bicarb 16.
Metabolic
Metabolic acidosis
Metabolic
with
acidosis
with
uncompensated.
compensated.
pH 7.41, CO2 26, bicarb 17.
Compensated
metabolic
acidosis.
acidosis with compensated.
This is a metabolic acidosis fully compensated.
Yes, sir.
And respiratory alkalosis fully compensated. Because here PCO2 is low, pH is even though it's normal, bicarb also has gone down. Yeah? So this is a fully compensated condition. pH 7.39, PaCO2 48, and bicarb 28.
Respiratory
So respiratory acidosis fully
with fully
compensated because
compensated.
pH has come back to normal.
Sir, for the previous one, sir, actually I have a small
Ah.
doubt, sir. Can it not be for the 11th ABG, sir?
Which one?
The 11th one, sir.
11th one.
Sir, can it not be metabolic acidosis which is compensated, sir?
Yeah, it should be.
Yes,
Yeah.
yes.
Correct. Because PCO2 is low,
Low, sir.
but pH is almost normal range. Bicarb is quite low. Yeah, it's wrongly said. Correct. It should be metabolic acidosis fully compensated.
Fully
Okay,
compensated.
not respiratory. And it is 7.42. So respiratory acidosis uncompensated. Bicarb is low. And pH 7.37.
With fully compensated. Metabolic acidosis with fully compensated.
Metabolic acidosis fully compensated. It's 7.22, PaCO2 49,
Acidosis.
bicarb 28.
Respiratory acidosis.
Respiratory
Respiratory
acidosis.
Respiratory acidosis partially compensated.
Partially
Because
compensated.
pH is not come back
Not-
to normal. So pH 7.42, PaCO2 32, bicarb 18.
Metabolic acidosis partially compensated.
Partially compensated. I mean fully compensated. pH is within normal range. Okay? PaCO2 is washing out. So primary problem is first PaCO2. Here there is a catch in this. You have to find out whether it is if it is respiratory alkalosis where there is a washout of carbon dioxide. Bicarb also gets reduced to prevent the and because we are losing hydrogen ions. If you have normal bicarb, that will make blood more alkaline. So that is how the compensation happens. So that is how the value gets corrected. Now we'll go to see some of the case scenarios. A 75-year-old gentleman living in a community being assessed for home oxygen, and this is the value CO2 8, CO2 7.6, bicarb 31, pH is within normal range. So what is the interpretation of this ADG?
Respiratory acidosis, sir.
Respiratory acidosis
With
fully compensated or not?
fully compensated, sir.
pH is normal. Bicarb is also gone up to compensate for the acid that is accumulating because of that.
But
So
he
this
would
is a compensated respiratory acidosis. So this does not represent any acute pathology, rather it reflects a compensation for chronic respiratory acidosis secondary to chronic pulmonary disease. So this is a acidosis with normal pH. So that is the mechanism of bicarbonate, how it comes down. This one. A 21-year-old man diagnosed as Hashimoto's thyroiditis, history of vomiting 1 week, and the ABG shows these values, which is 1.31, PCO2 39, CO2 29, bicarb 19, base excess 7, sodium, potassium, chloride, and glucose. So, what is this condition? pH is low, bicarb is low, PCO2 normal. CO2 is just low. What is the primary deficit here?
Metabolic acidic
Metabolic acidosis.
acidosis with partially compensated.
So pH is 7.3, bicarb is 19. So PCO2 compensation is 38.0. So it is PCO2 calculation compensation is good, but pH is not returned. What is the anion gap in this case?
It's raised anion gap, sir. 23, sir.
23.
8,
114 minus 72 plus 19. 81, 91. Okay, 23, correct. So there is it's a pure neon gas acidosis, and both sodium and potassium are high. So it is likely to be sodium is low and potassium is high. It is likely to be a metabolic disorder called Addison's disease. Now you are called in to see a 54-year-old lady in the ward. She is 3 days post cholecystectomy and has been complaining of shortness of breath. Her ABG is as follows. pH is on the outside, alkalotic or acidic? Alkalotic. CO2 is low and PCO2 is also low. Bicarb normal. So what is the interpretation?
Respiratory alkalosis that is with partially compensated.
Partially compensated by the. So what could be the cause for this?
Pain, so she's hyperventilating.
Very good. So this could be the type 1 respiratory failure. CO2 is low with the low CO2, accompanied by alkalosis in response to patient blowing of carbon dioxide, likely due to high respiratory rate because of pain. So the other differential diagnosis for this
Pulmonary embolism, sir.
embolism. Okay. Embolism, pneumonia, asthma, edema, pneumothorax, severe reflux cases. Okay. All these things can produce a similar picture. So you have to keep all these things in your mind. What should be done for this patient?
Adequate analgesia.
Look at the patient actually unwell, BCD, call for help. All these conditions can be tachypneic tachycardic. These will be prominent in asthma. Pyrexia points to pneumonia. PE can be a mild pyrexia. Pulmonary embolus will be the only condition that will be likely to be normal on auscultation. Take a full history, sudden onset, more likely to be PE, total cough, more likely to be pneumonia, raised JVP, anti-swelling, likely to be edema. Management, always keep this PE in the back of the mind because second or third post-op is one of the important things that you have to realize. Now, a 21-year-old female presents with acutely lightheaded shortness of breath, and she has final university exams next week with all of you, and the pH is 7.48, CO2 normal, PCO2 low, bicarb 22.
Respiratory alkalosis with the
Alkalosis, okay,
partially compensated.
partially compensated. Respiratory alkalemia, differential diagnosis, hypermetabolic state, pain or anxiety. Okay. So the anxious patient who is short of breath and persistently tachycardia, almost in also, sometimes we have to think of PE. A 32-year-old man presents with emergency, having been found collapsed by his girlfriend. pH is on the acidotic side. CO2 is normal. PCO2 is low. Bicarb is very extremely low. BSHS is -15. Potassium is normal. Sodium is normal. Chloride is normal. What is the anion gap in this case?
Increased anion gap, sir. Value is 30 around.
Value is actually, we can calculate, no? 139.5 minus 139.5.
Yes, sir. Increased cat.
And so chloride also 100, bicarb is 11, sorry, it is 28.
So 28.
Normal range is 7 to 80.
Mhm.
So there is a raised anion gap. What the cause of metabolic
Mud
acidosis?
piles, sir.
Mud piles.
Methanol, uremia, diabetic ketoacidosis,
So
lactic.
this is the mud piles. You have to think of this pneumonia, methanol, uremia. This is a 67-year-old man with a septic ulcer with persistent vomiting. pH is alkalotic. O2 is normal. PCO2 is normal. Bicarb is high. So what is this condition?
Metabolic alkaline.
Metabolic alkalosis.
Metabolic alkalemia.
Alkalosis with compensate.
Differential. What is the difference between alkalosis and alkalemia? So the differential diagnosis: metabolic alkalosis, alkalemia, persistent vomiting, and also could be acute outlet obstruction, vomiting, or hyperaldosteronism, diuretic use, milk alkali syndrome, or nasal transfusion. These are the other causes which we have to think of. And a 17-year-old girl presents to the emergency after an argument with her boyfriend. She says he took a lot of tablets. He denies this, and an ABG is taken. What is the ABG report likely to be? What is your interpretation?
Metabolic acidosis with compensation, sir. Respiratory compensation.
Metabolic acidosis, which is 7.46, slightly 1 point more than 7.46. CO2 is normal. Bicarbonate, PCO2 is slightly low. Bicarbonate is normal.
Respiratory alkalosis.
This is the picture, mild respiratory alkalosis. Because PCO2 is low and pH is slightly elevated on the alkalotic side. So this is mild respiratory alkalosis initially. A few hours later, she says she's feeling increasingly unwell, complaining of ringing in her ears. And when you take a repeat sample, from alkalotic side, this has become grossly acidotic.
Metabolic
CO2
acidosis.
is still normal. PCO2 is low. Bicarb has dropped down to 9. So this is now
Metabolic acidosis with compensated.
with partial compensation. PCO2, although if we do the Winter's formula, we do not know. So this is a case of classic aspirin overdose. What is one important history to suggest that it could be aspirin overdose? The earlier thing, you see here is the second thing. There is a clue here. Complaining of ringing in the ears. Okay? The tinnitus is produced by aspirin overdose. So that is a very important history. That's a clue that we have to take. So how to manage aspirin overdose? So these are all case scenarios which I made it in like an ASCII. Sometimes they can give you all these values and then have questions following that. So preservation of presentation of aspirin overdose will be hyperventilation, sweating. So that is how initially she presented with a slight respiratory alkalosis. Then it turned to become acidotic severely, sweating, nausea, vomiting, epigastric pain, deafness, etc. Investigations must do the plasma salicylate assessment, paracetamol level also, because these are all over-the-counter medications. So people can get access to that easily. And then management, ABCD and supportive care, gastric lavage if the patient comes within 1 hour, activated charcoal, correct electrolyte abnormality, and then alkalinized urine will help to eliminate that. Monitors urea and electrolytes regularly, and in cases of severe go for hemodialysis. That is the ultimate goal. A normally fit and well patient, 11 years old boy, presents with diarrhea, vomiting, with complaints of non-specific abdominal pain. The venous blood sample shows gross acidosis, Q to normal, PCO2 lower, bicarb grossly reduced, very severe base deficit. Lactate is it normal or high?
Increased, sir. High.
Very much increased. Potassium is on the higher normal range. Glucose is normal or high?
Low, sir.
Glucose low, 22
22.
millimoles. It is
Normal,
not
sir.
milligrams.
Normal, sir.
80.
22
It's high.
to
It's high,
18.
sir.
High, sir.
High.
More than 14.
High.
High.
18.
This is, the unit is
Metabolic.
not here, but Western this thing, usually it is millimole. So 22 into 18, it is almost 400. 20 into 18 is 360, another 36. So 396 is the glucose in milligrams. So what is likely to be
Metabolic
Okay,
acidosis,
sir.
DKA.
PK? So this is a diabetic
Diabetic
ketoacidosis
ketoacidosis.
because the child is only 11 years old. What type of
Type 1
diabetes?
diabetes
Type
mellitus.
Juvenile, type 1 diabetes. So how to manage this patient?
Fluid registration with 10 to 15 ml per kg, normal saline, and followed by insulin 0.05 to 0.1 units per kg. After the correcting the insulin, we have to check the serum potassium level and we have to correct the potassium, sir. Serum.
The priorities are fluid resuscitation, insulin administration, and correction of potassium. Very good. So a 22-year-old lady with a known history of asthma presents to the emergency department with difficulty in breathing. Her initial ABG on 15 liters of oxygen shows pH 7.54. Acidosis or alkalosis?
Alkalosis.
CO2 10.
Normal, sir.
CO2 2.2. Bicarb 24. What is this?
Alkalosis.
Respiratory, primary respiratory alkalosis. The CO2 10 with 15 liters of oxygen, is it okay?
So, hypoxia. Type 2 respiratory failure.
So after the initial treatment, nurse calls you to review the patient. She says the patient is rate has come down, but she's looking more unwell. Repeat the ABG. Now pH has must come back to normal. CO2 is still going down. PCO2 is within normal range. Bicarb is okay, and other values are within normal range. So why the nurse feels that the patient is going down? One important value in this report. PO2 is going down from 10, it has gone down to 9.8. Okay. So this patient has asthma, ongoing difficulty, and the raising CO2 should be there, and in extremely worrying this because the patient is tiring. The patient should be managed in a high dependency UTI. So that going down and PCO2 increasing from the earlier one when she was hyperventilating, that is another indication that ventilation is setting in. A 62-year-old woman with history of diabetes, long smoking history, presents to the emergency department, worsening shortness of breath, and auscultation of chest, widespread crackles are there. We notice ankle edema also in this patient. ABG, pH is acidotic, CO2 is slightly low, PCO2 is raised more than the normal, and bicarb is also low. So, this primary metabolic, PCO2 is also high.
Respiratory acidosis, metabolic compensation.
Metabolic compensation means bicarb should go up, isn't it? Because respiratory acidosis will produce more hydrogen ions. So compensation should come in the form of increasing bicarbonate.
Compensated, sir.
Not compensated. Probably there is an element of metabolic acidosis also. Isn't it? So it will be a combined disease. Note that despite the low pH, the PCO2 is also high. This is a picture of mixed respiratory and metabolic acidosis. Given the history of diabetes and ankle swelling, renal failure is a unifying diagnosis with pulmonary edema contributing to respiratory acidosis, where the failure of clear acids causes metabolic acidosis. Okay, so give credence to all the values. Don't think that if it is a respiratory acidosis which is getting compensated, bicarb should elevate more than 26. Then only it will be compensated. Okay, so this is all the case scenarios which will be tricky to diagnose. So think of combined disorders. Lastly, before we close, the steward approach. That is another method of analyzing the acid-base. Earlier one was called Henderson-Hasselbalch, where they took only the carbon dioxide and bicarb into consideration, whereas Stewart said electron neutrality and mass conservation are the two principles upon which, and that is where your cation, anion, gas, everything comes in. And Stewart, he took these three parameters for maintenance of pH: carbon dioxide, strong ion difference, and total weak acid, that is albumin and phosphate. All the three contribute to pH according to Stewart theory. But earlier Henderson-Hasselbalch, he gave importance only to carbon dioxide and bicarbonate. The Stewart approach shows pH is not simply determined by hydrogen and bicarbonate alone, but it involves interaction of other variables like CO2, HIT, and weak acids also. Okay, so that's about the rough training on how to interpret ABG. Now going on to the pulmonary function test. Okay, how to perform pulmonary function tests? What are the, how do you classify pulmonary function tests? How are they done? Any sudden silence.
Static and dynamic.
Static and dynamic. Thorough history and examination, and patient's exercise tolerance, and then oxygen saturation before, during, and after a staircase climbing or some even walking. The history of any chronic sputum production, and pulmonary function test can be divided into tests of ventilation and gas exchange, and it also helps to find out the cardiopulmonary reserve. And the indications are for diagnosis of a disease, monitoring response to therapy, and any other use. So you can find out whether it is a obstructive airway disease or a restrictive. That is the diagnosis component, and whether it will respond to bronchodilator therapy or not. And course of the disease. In COPD, you can see whether it is worsening or improving. So documentation of the course of the disease. It is a very important tool for preoperative assessment for cases like lung resection, cardiac surgery, and non-cardiac thoracic surgery also, and the evaluation of disability. So that also will be found out by consultant, and evaluating disease prognosis, whether it will improve or it will become worse. Now, assessment of ventilation, how it can be done. It is done by the flow, the measure of peak expiratory flow rate during forced expiration. And its main role is peak flow to follow the obstructive disease such as asthma or COPD. It may be useful during exacerbations of this condition in assessing the response to treatment, and obtained in assessed in comparison. So pre-bronchodilator and post-bronchodilator therapies are usually given as a value in the reports that you find, and you have to take these parameters into consideration. Whenever you do the pulmonary function test, you should take the patient's step, age, height, and race, etc. into consideration. And normal diurnal variation of the flow will be with the lowest levels occurring during the early hours of the morning. So that is also very important when you do the timing. And for assessment of gas exchange, this is the transfer factor, PLCO, which is important, and it is performed in a laboratory using a single breath mixture of 110% xenon or helium and the carbon monoxide, and patient holds the breath 10 to 20 seconds and then exhales. In the first exhaled death stage gas is discarded following analysis, and helium is not absorbed by the lungs. In helium concentration, the expired gas can be calculated. Of course, these are all methods of doing it. Just skip that. How is spirometry done? And what parameters are measured? This is the most practical thing that you have to remember. All of you attended a lot of workshops on cardiopulmonary testing nowadays, or pulmonary function testing. Every other CME has a workshop on that. So, how is the spirometry done? Have you ever gone to the PFP lab and seen? So, you use the forced respiratory volume in 1 second and forced vital capacity are measured using an instrument called oscillograph. And it also creates the flow volume loops. It also measures the mid expiratory flow rate. And the volumes and capacities that are measured are, so that is where we classify them into static and dynamic. The static lung function measures the 4 volumes and 4 capacities. And what is this instrument?
Wright's respirometer, sir.
Wright's respirometer, which can be used at the bedside to measure. What are the measurements you can make with that? Can you measure FEV1 in all of this?
No, sir.
No. You can measure only the static measurements, like vital capacity
And
and tidal volume can be measured. Okay? So, how is it used? Of course, it can be used with a mask or it can be used with a mouthpiece to blow. Mouthpiece is better because you will have a no leak. If you use a mask, there is a possibility of a leak through the sides. Whereas if the mouthpiece is used, you can cut the lips over the mouthpiece and then avoid the leaks. Now, what different tests comprise PFP? Okay, 6 different tests are there. Spirometry, 3 and 4 bronchodilators, flow volume loops, lung volumes, diffusing capacity, and bronchoprovocation challenge. These are all the different tests that can be done. What are the limitations of pulmonary function test?
Severe obstruction.
Hmm?
If the patient is severe obstruction, so he can't do pulmonary function.
Okay.
Active hemoptysis.
Hmm.
In chest pain.
Major limitation is actually where you can do it and then how it is useful or not. That is the meaning of this, not whether the patient will be able to do it. The major limitation is how they are interpreted and whether the PFT is reliable, because the patient effort is very, very important in doing this. So sometimes they may understand or may not understand properly, and many values in the report are organized approach to different. Important to know how to approach them. And finally, reference values in the PFTC are not absolute cutoff values. They are that is why the sex, weight, height, the race, etc., they all produce a sort of wide range from which you cannot conclusively say that the values are absolutely correct. So these are all some of the limitations of that, not with whether the patient is able to do it or not. After doing that, what are the limitations? So these are the 4 limitations you have to know, that the person interpreting this should have a good idea about that, and whether it is reliable, whether it is approached in an organized way, and whether the reference values are reasonably okay when you compare it with the actual values. Okay. What is the significance of post-dilator response? How it is calculated? So significant BDR response, either FEV1 or an FEC, increase more than 10% of the predicted values. So this is how you should always try to interpret that. And the equation for calculation is, so this will be more. Now, just like the ABG, what are the steps of PFT interpretation? I showed you the 6 steps of interpreting ABG. Similarly, are there any steps for PFT interpretation? If supposing they give you a PFT report in your hand and ask you to interpret, just like ABG, what is the first thing you should look at?
Demographics.
Here also the demographics, the clinical scenario, and look at the demographics of the patient. Before PFT results can be reliably interpreted, 3 factors must be confirmed. One is volume time curve reaches a plateau and expiration lasts at least 6 seconds. So this is how the volume time graph should be seen. And the results of 2 best efforts in the PST are within 0.2, that is 200 ml of each other. Then only it is considered as consistent. The results of, actually they will ask the patient to do every test 3 times and take the best out of the 3. And when they do that, 2 best efforts should have only a difference of less than 200 ml. And the flow volume loops are free of artifacts and abnormalities, like coughing or holding. All that should not be there when you interpret the flow volume loops. So these are the 3 important things that you should make sure. And the first thing you do is determine if the FEV1 to FEC ratio is low or not. If it is low, what does it mean?
Obstructive. Obstruction.
Obstructive air disease. Then determine if the FEC is low. If the FEC is also low,
Obstructive.
if FEC is low and FEV1 to FEC ratio is normal, what does it indicate?
Restrict. Could be normal or
Restrictive.
restrictive.
So it is a restrictive disease. So confirm restrictive or obstructive pattern is total lung capacity. That is how you can confirm that. And grade the severity of abnormality and determine reversibility with obstructive defect. Okay? So these are the 6 steps that you should do. So after assessing the demographic and then the correctness of doing the test, are the things. First, determine FEP, FEC ratio, see whether FEC is low, see the total lung capacity, and assess the severity of restrictive or obstructive disease, and see the response to bronchodilator. And then bronchoprovocation and establishing the differential diagnosis. These are all further tests to be done. These first 6, once you decide, then we go for the rest of the thing. How to differentiate between restrictive and obstructive and mixed disorders? What will be the values in if it is a purely obstructive airway disease? What will be the FEV1? What will be the FEV1 to FVC ratio? What will be the TLC?
FEV1 by FVC ratio will be reduced.
What first FEV1 value? That itself will be reduced.
Reduced.
What is FEV1?
Forced expression to
First expression at first second.
First second. How much percentage of the tidal volume should be expelled in the first second? What? Supposing you have
70%.
80%.
80.
80%. Okay. So if you have a tidal volume of 500 ml, the first 400 ml should be expelled in the first second. Then the balance 100 ml should be expelled in the next 1 second or second. So that is the FEV1 value is the first one you have to take. Then FEV1 to FVC ratio. Then total capacity will be reached somehow in obstructive disease. Whereas in restricted disease, the TLC will be low. Okay? So forced vital capacity, FEV1 in 1 second, FEV1's ratio, total lung capacity. So this is how you have to do that. And in obstructive pattern, FEC will be reduced, FEV1 also will be reduced, ratio will be decreased, and total capacity will be normal or sometimes increased because of air traffic. Whereas in restrictive pattern, FEC is decreased, FEV1 is also decreased or normal, but the ratio between FEV1 to FEC will be normal and restrictive, but the total capacity will be decreased. Okay, so this is how we find out. And in different diseases, restrictive, we can in this. Mixed diseases, when you have both obstructive and restrictive, FEV1 to FVC ratio will be lower than normal, plus TLC also will be lower than normal. So if both are present, here in the pure obstructive, TLC is normal, whereas pure restrictive, it is decreased. Whereas if it is a combined one, instead of TLC being normal, that is also will be decreased. Then you think of restrictive and obstructive pattern. So these are all the various changes that we'll have in these types of disease. So here is a case scenario. 29-year-old woman presents to your clinic with episodes of shortness of breath, chest tightness, wheezing during springtime. The interpreter PFT as follows. So these are all the values, and these are all the options. A normal spirometry, obstructive pattern, restrictive pattern, mixed obstructive restrictive pattern. So if you see the FVC first, the predicted is 4.32, but the actual is 4.39. The percentage of prediction is 102. FEV1 predicted is 3.37, actual is 3.2. So 95% of the predicted is being done by actual. FE1 to FEC ratio is 0.73 actual, predicted is 7.8. So percentage not available. FRC is almost normal. Residual volume is also slightly high compared to the predicted value. Total capacity is also high compared to normal. So do you think it is What is the interpretation? What is your selection among these four? Will you say it is a normal spirometry and lung volume, or is there any obstructive or restrictive pattern or a mixed obstructive pattern?
Could be obstructive pattern, sir.
Mixed obstructive and restrictive pattern.
Why you want to say mixed? All values are predicted
Normal,
values are normal, more than sometimes even higher than the predicted value.
But air trapping,
Air trapping. The PLC is high. So it's a normal spirometry and normal lung volume. Okay. Thus, this presents to your clinic even though she has shortness of breath, chest tightness, wheezing during springtime. So this is only a seasonal asthma. But for now, what at time of doing this, there is nothing, no problems at all. Okay, so don't think that it will always be a pathological condition which will be given. Okay, so if the predicted and actual values are almost matching each other, you can boldly say it is a normal pulmonary function testing. Okay.
yes, sir.
Now this is another. Your suspicion is that this patient has asthma. Please now. So this is the same thing being analyzed based on this lung function. The suspicion that this patient has asthma is decreased normal lung function rules out asthma. Unchanged clinical history suggestive of many patients with asthma have normal spirometry sometimes. And I can't tell as a bronchodilator response was not assessed also.
It is unchanged.
Now, here please to evaluate for asthma, spirometry, both pre and bronchodilator should be done. A normal spirometry does not exclude diagnosis of asthma. Additional steps are required, like bronchoprovocation therapy, empathic therapy, and the evaluation of the asthma. So, if you do a flow volume loop, what will be the picture if it is a true asthma? Which phase of the flow volume loop will be affected?
Expiratory phase, sir.
Expiratory phase. So what will happen to this is the expiratory phase, isn't it? Top one. The bottom is inspiratory.
A scoop out of the
Scoop out will be appearance. Yeah, we will see that later. Now this is another case scenario. Interpret this PFP. The PC predicted is 5.30, but the actual best is only 3.05, 58% of the predicted value. FEV1 predicted is 3.9, that is also low, 1.65. Ratio is also low, and FEV1, of course, the mid airflow is all that. Lung volume, vital capacity is low, total capacity is also low, residual volume marginally low, and diffusion capacity is also very grossly low, and the diffusion adjustment is also very badly. Post bronchodilator therapy, there is not much of a change. From 3.05, it has come to 3.08. FEV1 also is hardly any increase. The ratio is also almost the same. So, what is the main interpretation based on this all red values? And of course, here also the values are quite low. So, what is that pattern, whether it's obstructive or restrictive? Already I have shown you how to,
obstructive, sir.
the major obstructive, but TLC is also very grossly low, isn't it?
Yes, sir.
So,
Mixed.
The choices are
Mixed
whether it is
obstructive and
normal, obstructive, restrictive, or mixed obstructive, restrictive. It's your choice.
Mixed
One A.
obstructive.
Mixed obstructive.
It is B. Because TLJ
Slow.
also is low.
Yes.
Total capacity is also low. So this is a mixed obstructive restrictive pattern. Okay? So even though it is very severe obstructive pattern, it is also there is an element of restrictive pattern because of the low TLC. So it's a low FEC, FE1, FE1 ratio, TLC. That is the reason to say it is a mixed pattern. Now there is another example. This is the predicted. FEC is low, FE1 is also low. Both bronchodilator also not much of improvement, but here the FEC improves almost to 82%. And the total capacity is
Increased.
higher than normal, 136. So
Obstructive.
Obstructive.
Yes.
options are the same: normal, obstructive, restrictive, mixed.
Obstructive.
It's an obstructive with an
Yes.
improvement in
Bronchodilator.
bronchodilator. Okay, so this is an obstructive pattern because TLC is also high. It is so air trapping. So 6.4 is 8.73. So there is a probably already anticipated changes have come. So the reason for making a diagnosis of obstructive is low FEC, low FE1, FE1 to FEC ratio, normal high TLC and residual volume. All these things so it's an obstructive pattern. Now describe the flow volume loop shown here.
A is normal, B is obstructive, C is restrictive, sir.
Please,
Fixed intrathoracic obstructions.
pardon?
C is fixed intrathoracic obstruction.
C is fixed intrathoracic obstruction. Yeah, fixed large way obstruction is C. B is obstructive airway disease and C is normal. What is this?
Time volume.
Time.
Volume.
So this is a
Blue line is normal.
expiratory site, volume time curve. So here the green is the
Obstructive.
obstructive tab, blue is the normal one, and
Right.
F is the restricted
Restrictive pattern.
pattern. So remember this picture, sometimes we may show all this. Now what is shown here?
First one is normal.
A is
Normal
Time
time
volume.
volume.
Now what is shown here? First of all,
The
what
The
is
time volume, first is time volume and
four
second and
spirogram
fourth is
tracings, two are volume versus time, two are volume
volume.
versus flow pattern. Okay, that is the first answer you had. What is shown here, that is the answer. Now, which of the four are normal, which are abnormal?
Below 2 are abnormal.
Below two are abnormal. Top two are acceptable. Bottom left by variable section. Bottom right is cough
Cough.
induced. Now, case scenarios for patient conditions. A 64-year-old woman presents with complaints of dyspnea and orthopnea. She has a lifelong non-smoker. Pulmonary function testing is as follows. FEC only 40% of the predicted, right? Low. FE1 is also only 30% of predicted low. FE1 to FEC ratio is also decreased. Residual volume and total capacity are also reduced. And FEC upright also given. A flow volume loop is shown here. So this is the interpretation.
Restrictive, sir.
Restrictive. What about the
Obstructive.
FE?
Obstruction.
Yeah, why does it not thinking of mixed disorders? Only more choice than that. It could be restrictive, purely obstructive, mixed disorders. So when you have a FEV1, FEC, all these things reduced as well as the total capacity is also only 52%
Reduced.
of the original. So it is a mixed disorder. Patient has reduced FEV1 and FEC with a reduced FE1 to FEC ratio, so that will be classified as obstructive. However, she has a low TLC. This is evidence of restrictive defect. Therefore, the patient will be labeled as a combined obstructive restrictive defect. Now, coming to the DLCO2, not provided, which makes it difficult to determine if the cause of restriction is due to pulmonary parenchymal process or an extrapulmonary process. Okay? The important clue comes from her history. Patient reports orthopnea. Although this is classically seen in patients with heart failure, it is not specific for this disease. Patients with diaphragmatic weakness can also present with this symptom. They lie supine, gravity no longer exerts an effect on the diaphragm and abdominal contents. Patients have trouble getting their diaphragm to descend against the abdominal content. And the presence of diaphragmatic weakness is confirmed by repeating their pulmonary function test. That is why they have done the upright and supine also here. And in supine, you can see it is far less than the normal. So when she is supine, FE1 to FEC both fall by greater than 20%. Thus providing evidence that she is in fact have a diaphragmatic weakness as a cause of her lung restriction. So how to determine the validity of this function test? If the FEV1 to FEC measurements are within, that is what I told you, just like finding out the internal
Consistency.
consistency in ABG, this is the important factor to find out whether the FE1 to FEC measurements are within 200 ml of each other during the two best efforts, consistently able to reproduce the responses. Another case scenario, a 73-year-old man presents with progressive dyspnea on exertion, past 1 year, reports dry cough but no wheeze, sputum production, fevers and hemoptysis. Is lifelong non-smoker, worked as a lawyer until retiring 3 years ago. He likes to hunt and fish in his leisure time. His pulmonary function tests are as follows. FEC grossly reduced, FEV1 badly reduced, ratio is almost normal. FEV1 to FEC ratio actually is better than the predicted, and total lung capacity is grossly low. I mean, total capacity is very much restricted, lower than the predicted value, 42% only. And this is the flow volume loop picture. So what is the interpretation?
Restrictive, sir.
Purely restrictive. Here, restrictive as well as the obstructive.
Mixed.
Because the FEC, FE1 are reduced, but even though they are reduced, this is normal. The FE1 to FEC ratio. So this is more of a restrictive pattern. Okay? Even though FE1 to FEC are all reduced, it is because this ratio is also maintained. It is a purely restrictive disease. The patient has reduced FE1 to FEC, but a preserved FE1 to FEC ratio. And the total capacity, lung capacity is reduced, so this is the restrictive defect. Flow volume loop also has the characteristic long tail appearance. Okay? So these are all the test criteria. So this is a restrictive lung disease with a diffusion defect. So another case scenario, 44-year-old woman with cirrhosis secondary to chronic alcohol abuse, hepatitis C presents with complaints of increasing dyspnea. She reports that her dyspnea is worse when she is sitting up upright and walking, but improves when she is lying flat. She is an active cigarette smoker. She has a room air oxygen saturation 88% in the sitting position. The air oxygen saturation 96 when lying down or supine. The pulmonary function tests are as follows. FEC almost normal, 107%. The FEV1 is also 91%. The FEV1 to FEV ratio slightly reduced, and total capacity is almost normal, and DLCO2 is corrected is 10.22 compared to 28.2. So what is the interpretation? Everything is important from the history to the report that is given here. All should be taken into consideration. Is there any restrictive or obstructive or a mixed pattern here?
No, sir. No, sir.
No. So all these values are almost normal except for
DLCO.
DLCO2. So what is this? He has a history of cirrhosis.
So orthodoxia.
Ah, fantastic. So this is a case of normal FEC, FE1, slightly reduced FE1 to FE3, even though FE1 within normal rate, there is a mild obstructive lung disease because of the probably ascites. No evidence of a bronchodilator response is there. However, a DLCO2 is markedly reduced, which is out of proportion, and this suggests he has a pulmonary vascular problem. So patients with cirrhosis are supposed to have severe pulmonary vascular problems, including portopulmonary hypertension and hepatopulmonary syndrome. So the latter disorder is marked by presence of intrapulmonary shunt, which occur predominantly at the base of the lung. So both these problems can be isolated only by DLCO. So ultimately, mild obstructive lung disease with diffuse defect is causing or called as orthodeoxia and or portopulmonary. Another case scenario, 36-year-old woman presents with several months history of worsening dyspnea and exertion, exercise limitation, is on lifelong non-smoker, no history of asthma or other pulmonary diseases. She had to stop going out for walking and running because she no longer keep up with her friends. Her pulmonary function tests are FEC grossly reduced, only 26% of predicted. FEV1 is also reduced to 30% of predicted. FEV1 to FEC ratio is well preserved.
So normal.
Total capacity is reduced.
Mixed.
Normal. DLCO2 is slightly reduced.
Restrictive.
Restrictive.
Restrictive. Patient has reduced FEV1 with that, suggestive of not that. The TLC confirms the presence of restrictive disease. Okay? So based on the fact that TLC is only 53% of predicted, this should be labeled as a moderate restrictive defect, and patient has essentially normal DLCO2, more or less close to 78%. And although this value is technically less than 80% of predicted, due to the inherent variability in the test, the values can be considered normal. This suggests that our alveolar capillary interface of gas is changed for normal, and further suggests that the restrictive process is due to extrinsic to the pulmonary parenchyma. Okay? So this may be the reason. He has got some physical deformity in the form of spine abnormality. So moderate restrictive disease with normal diffusion. That is the diagnosis. 53-year-old woman Presents with increasing dyspnea on exertion. He denies cough, fever, hemoptysis, weight loss, or sweat. He was previously an active runner but has now come back significantly because of symptoms. He just note occasional chest pain with exercising but has not had any syncope or palpitation. Results are like this. FEC almost 83% of prediction. FEV1 is also 84% of the predicted value. FE1 to FEC ratio is well preserved, and total lung capacity is also almost normal, and the diffusion capacity is 43% of predicted, and our flow volume loop is like that. There is a value given post bronchodilator. The FEC not much of a change, and FE1 also not much of a change. In fact, it is less than the pre-bronchodilator, and the FE1 to FEC ratio is very much preserved. So, what is the interpretation here?
Anemia, sir.
Anemia. No, first of all, whether it is a normal pulmonary function or whether it is restrictive or obstructive or a mixed disorder.
Looks like it's normal, sir, because only
Normal.
TLCO is reduced.
Normal FE1, FEC, preserved FE1. So she has a normal total lung capacity. As a result, there is no evidence of either obstructive or restrictive disease. Okay. However, indicating that she has reduced alveolar exchange based on the DLCO2 is only 43%. So there is a diffusion defect here mainly. So the finding is isolated DLCO, the normal spirometry and lung volume suggest a pulmonary vascular process such as pulmonary hypertension. So this patient in fact found to have pulmonary hypertension due to chronic thromboembolic disease. So what are the features of pulmonary hypertension?
Pulmonary arterial pressure could be more than 35 mm of
25.
mercury.
No. That is after we investigate. But what will the patient have? Here already
Exercise tolerance will be reduced.
dyspnea on exertion and
Hemoptysis.
Fatigability.
so the
Typhoid
features
failure.
are, it can be blue lips or skin, chest pain, fluttering chest sensation, shortness of breath, fatigue, weakness, tired, and lightheadedness, dry coughing, abdominal bloating, rapid weight gain, swollen ankles because of right heart failure. Okay, so these are all the features of pulmonary hypertension. So there is a moderate diffusion defect with a normal pulmonary function. Okay, so PFT is within normal limits. A 35-year-old previously healthy man presents with dyspnea, fever, chills, and the night sweats for the past 2 months. He is a non-smoker, no concerning habits, and occasional exposure. His pulmonary function tests are as follows. FEC very much reduced. FEV1 is also reduced, and FE1 to FEC ratio also reduced. Total lung capacity is also reduced, 54%. The RV is also lower. The RV to TLC ratio here is actual is 45, predicted is 29. That is the only thing which is giving a little bit. Flattering of second part of the expiratory lane. That is the flow volume group. Is there any obstructive or restrictive element or a combined mixed element?
Mixed elements. sir.
Combined, sir.
So patient has reduced FE1, FEC with a low FEC ratio consistent with obstructive. He has also low TLC indicating a restrictive process as well. Would therefore be labeled as a mixed obstructive restrictive disease. This obstructive disease being more severe than that. And there is an interesting finding in this flow volume loop as well. The expiratory limb appears to have two components. There is a steep component and then there is a flatter component over the latter half of circulation. This pattern suggests that one lung may be emptying faster than the other. Therefore, the slow emptying lung might have an obstructing airway lesion. So, in fact, when the patient underwent chest X-ray, he was found to have a dense opacity in the right chest. CT scanning revealed the presence of large mass. This mass was so large it was not only collapsed in the right lung but also compressed the left lung, causing lung restriction. It also compressed the airways on the right side, leading to obstruction of airflow out of variable right lung. These images are given below. So this is the X-ray chest which showed that. So this is a mixed obstructive restrictive disease. Okay. 65-year-old man undergoing pulmonary function test as part of routine health screening and no pulmonary complaints. He is a lifelong non-smoker and no prior history of asbestos exposure while serving in the Navy. His functional values are FEC is very good, 100% of prediction. FE1 is also 95%. Then ratio is also normal. PLC is also normal. RB is also normal. BLCO2 is also fine. His flow volume loop is also like this. What is the inference?
Normal.
Normal, sir.
Normal. So the demonstrates a normal pulmonary function test. So all these things are almost close to normal. Flow volume loop predicts all darkened surface. You would conclude that there is no evidence of airflow obstruction. Patient also has a normal lung capacity, indicating there is no evidence of restriction. With a normal diffusing capacity, indicating alveolar capillary, and there is no bronchodilator report. So this is a normal PFT. Okay. So, a 54-year-old man presents his primary care provider with dyspnea and cough. He is a non-smoker with no relevant occupational diseases. FEC is slightly reduced. FEV1 is also slightly reduced. FEV2 ratio is also slightly reduced. But after bronchodilator therapy, everything seems to beautifully increase. FEC is increased. FEV1 is also increased. The FEV1 to FEC ratio also increased. So there is a pre predicted peak flow and actual peak flow is present in these things. So what is your preference?
Asthma, sir.
Reversible.
Bronchoconstriction. Reversible.
Okay. Both are below the normal for a limit defined as 80%. Here it is 64. Even though it is all reduced. So in addition, there is also a lower limit of normal of the predicted for male. So here it is the airflow obstruction of moderate caliber, not very severe, and it is a good response following the mistake. So bronchodilator responsive obstructive disease. Okay. So this is a milder form of. A 60-year-old man presents with primary care provider complains of increasing dyspnea on exertion. He has 40-pack-year history of smoking, retired following a career as a building contractor. Pulmonary function testings are FEC grossly reduced, FE1 grossly reduced, FE1 to FEC ratio also very bad, reduced, and total capacity is more than prediction, 117%. Diffusion is also reduced, and this is the flow volume loop that is being seen here. So what is the answer?
Obstructive pattern, sir.
Pure obstructive pattern. Okay, so the patient has a abnormal spirometry. So this is a severe airflow obstruction. So severe obstruction with air trapping because the TLC is very high compared to the normal. And here another scenario, 25-year-old man presents to the physician with complaints of dyspnea and wheezing, non-smoker. 2 years ago, he had a major motor vehicle accident, hospitalized for 3 months. He had a tracheostomy placed because he remained on the ventilator for 7 weeks. The tracheostomy was removed 2 months after his discharge from the hospital. His pulmonary function testings are like this. The PC is normal, FEV1 is slightly reduced, FE1 to PC ratio is also slightly reduced. Actual is 54, predicted is 85. But this flow volume loop is very characteristic. Flattened expiratory limb, flattened inspiratory limb. What is the diagnosis?
Fixed upper airway obstruction.
Fixed airway obstruction. Very good. So it is mainly by this we have to make the patient has evidence of airflow obstruction on spirometry, and he has a low FEV1 and reduced FEV1 ratio. Given that 69%, we be labeled as an obstructive airway disease. But to make a correct diagnosis, we have to go for the flow volume loops. So based on the flow volume loop. So what are these patterns? This is fixed obstruction. What is this and what is this?
Second one is
Second one is extra thoracic obstruction.
And third one
is normal. The inspiration is flattened here. So this is extrathoracic. And the inspiration is normal, expiration is flattened. This is intrathoracic. So the opposite. Okay.
Yes, sir.
So the identify the conditions. This is fixed obstruction. This is variable obstruction, which is extrathoracic, and this is variable obstruction, which is intrathoracic. Okay. So this is intrathoracic expiration will be flattened. Extrathoracic inspiration will be flattened. So remember that way opposite. So this is how they. A 41-year-old woman presents to the general internal medicine clinic at medical center complaining of dyspnea with mild exertion. She has a 10-year history of smoking and history of using intravenous drugs including heroin and Alkaline. Her pulmonary function tests are as follows. FEC only 29% of prediction, very grossly reduced. FEV1 is also only 19%. FE1 to FEC ratio also very low. TLC is almost normal. And RV TLC ratio is more than 30%. And diffusion is grossly reduced. And this is the flow volume loop. There's a prediction. See, so much time for this.
Obstructive.
These are all values showing that pure obstructive disease, isn't it? But the flow volume loop, does it go into that obstructive feature? Of course, there is a scooping of the expiratory, but the whole thing is looking very small, isn't it? The patient has airflow obstruction features. FE1, FEC are all decreased. Our flow volume loop demonstrates a characteristic scooped out appearance seen in the obstructive disease. This should be classified as a very severe disease and unlikely for a 41-year-old person to have obstructive lung disease, only 10 years smoking history. Asthma is unlikely diagnosis given the absence of reversibility. Of course, post bronchodilator also not much of improvement. So this patient has severe obstructive disease with air trapping and diffusion defect also because of the DLC that is very huge. So there is a minor fissure shifted upward in the right side, indicating that lower lobes are overinflated. The two disorders give you an early onset emphysema with bacillar prominence. Alpha 1 antitrypsin deficiency may be the cause for all this. And what is the importance of limits of normal PFT interpretation? A healthy population according to normal distribution curve will have fall within the first percentile. For example, so technique of performing the parametry, that significance of dilator response, low volume loops. Right? DLCO2 test interpretation, emphysema less than lower limit of normal, chronic bronchitis, DLCO2 is normal, intrinsic lung diseases also will have lower than normal, extrinsic it will have a normal DLCO2, and these will be the features in all these various lung disorders. And assess the bronchodilator therapy. You have to take 4 puffs of albuterol with a stager, wait for 15 minutes, and then 3 bronchodilator post-bronchodilator therapy. Improvement by 12% or 200 cc is considered as good response. And the methods of determining the validity of now we'll see some capnograph pictures. Okay. Can we identify this?
Esophageal intubation, sir.
These are all normal patterns. Gradually it is going down, and so this is a gradual decreasing EPCO2 tracing. That's all we can say from this. Okay, unless
Yes,
we have 6 tracings, we cannot definitely say whether it is esophageal intubation or not. So gold standard is we must have 6 tracings shown in the picture. Then only you can say whether it is. What is this?
Return of spontaneous circulation.
Return of spontaneous circulation. Very good. What is this?
Rebreathing.
Breathing with hypoventilation leading to hypercarbia also can be there. And what is this?
Normal.
Normal.
Normal
Normal
EPCO2.
capnogram. Now, what does this phase 1 represent?
Space.
Expiration.
Dead space. And what is this phase 2?
Expiration. Expiration.
Starting of stroke of expiration. And what
Plateau.
is this?
It's alveolar
Plateau. What is alpha angle? What is the value of alpha angle?
90 to
90 to 110.
90 is beta. Alpha is supposed to be 100.
110.
Okay? And what is the importance of alpha and what does beta represent?
Intidal carbon dioxide indicate beta.
If beta angle is increased, it could be bronchospasm.
Beta angle?
Raised beta angle, it could be obstructions.
Alpha angle. Let's find out the answer. Okay. So this is apnea. What is this?
Curare clefts.
Curare cleft spontaneous.
Curare cleft alone?
With the spontaneous efforts also.
Spontaneous effort.
This also has to be taken into consideration. Okay. Spontaneous assumptions with the curare cleft. Okay. Don't forget this. If you write only curare cleft, you will get only half the mark. Now we have various patterns shown here.
Shark fin appearance.
This is a
Bronchospasm.
Bronchospasm.
bronchospasm with widening of the alpha angle. Okay. Almost after some time it will become sharp fin. What is this?
Cardiac oscillation.
Cardiac oscillation. What is this?
It could be complaints of lung, reduced complaints of lung,
Increase in pregnancy,
pregnancy.
increased compliance.
It's supposed to be a leak.
Shock or alveolar leaking.
Alveolar. And this is the 40 is almost 20. Hypoventilation.
Hypoventilation.
Low cardia. Okay. And this one, a hump here at the beta angle level, alpha angle level. It's supposed to be lung transplant. Okay. So we have the two different segments. And here, this line is above the
Rebreathing.
Baseline.
deep breathing with the hypercapnia.
Hypoventilation.
What is this? It's a time volume
Volume capnogram.
volume capnogram. Okay. Wait. What is this?
Sudden discomfort or cardiac arrest.
Huh?
Gradual decrease in ETC.
How to describe that? Front capnograph showing loss of bracing. Okay. What is this? This is also trend. See, when the bracings are very close to each other, this is called the trend pattern display. Okay. So here you have this up to 40, then suddenly it goes up. So
Increased of days.
front capnogram showing assisted breath in between spontaneous breathing. What are the possible causes of ETCO2 less than 5 millimeters? How to rectify that?
Disconnection.
So the mnemonic you have to remember for that is DOPE, displacement, obstruction, pneumothorax, and equipment. So that is how you remember that. What is this capnograph called?
Ventilator
Huh?
patient dysynchrony. Ventilator patient asynchrony.
Ventilator patient patient.
Signature
The hump is there in the inspiratory.
Okay, sir.
There's nothing in the expiratory upstroke or the plateau. There is an inspiratory phase, there is an upstroke. So this is a capnogram showing inspiratory attempts. This happens during spontaneous breathing while using vein circuit. This is called the signature capnogram. This sort of thing is called a signature capnogram. Of course, these are all various capnograms that you see, and this particular one, the lower one. So, what does this capnogram show? Sorry. The mouse has stopped working. So, what is this particular capnogram show? There is a small peaking at the end of the expiration at the beta angle level. When does it happen?
Increased compliance.
Obesity or in pregnancy. Okay, so this is called sometimes called the pigtail appearance. Okay, so that is can happen. That also will be given in the exam. So these are all the various capnographic diagnosis that will be given in the exam. One is esophageal intubation, 6 waveforms, decreasing height, right main bronchus intubation, decreasing the same thing, bicep capnogram, curare cleft, which is very common, cardiogenic oscillations, camel hump seen in lateral position, and rebreathing capnogram using Mapleson D, that is what is called the signature capnogram. And phase 4 in pregnancy is the one that I showed in the last one. And dilution of expiratory gases by forward flow, first gases prior to the later in that. That will look like some arrows coming in a sequence. Instead of the sharp in appearance, imagine triangles being placed in sequence. That will be the appearance of that forward flow. And reverse phase 3 will be seen in emphysema. And sticking of respiratory valve malfunction, mandatory versus spontaneous triggered breaths, dual capnogram in lung transplant, hair leak, and malignant hypothermia showing progressive increase in the CO2 and the air oxygen dilution during mass sampling and spontaneous breathing. These are all the things that can be kept in the examination. So just try to keep looking at those pictures, and that is the end of the thing. That completes ABG, PFT, and capnography. We'll quickly go through some X-rays.
Yes, sir.
Yes, sir.
Is it visible or
Not visible, sir.
No, sir.
visible? Is it visible?
Yes, sir.
Yes, sir.
What could be seen here?
Wedge-shaped opacity in the
X-ray
right
showing
Right low,
Consolidation,
lower
right
lobe
lower
consolidation.
lobe, clear lower zone. Okay, so this is the consolidation in the right lower lobe. What is found abnormal here?
extracardiac.
Extracardia.
Extracardia. Not only immediately is the extracardia. So heart on the right side with extracardia plus external wires are also seen here. Not only that, and loop preferred device is also there. Bowel gas is seen. Dextrocardia with situs inversus solidus.
Yes, sir.
Is seen here.
bilateral obliteration of cardiothoracic angles, cardiophrenic angles.
Audiophrenic angle suction.
By pleural effusion.
Two pulmonary edema.
Pulmonary edema.
Pleural effusion, so right sided pleural effusion.
Right sided hydropneumothorax. Because it's a flattening level. The air also there. Pleural effusion, you should have the meniscus. Okay.
Yes.
What is seen here?
Straightening at lifted body.
Surgical
COPD.
emphysema. You can see all the hair shadow under the skin. Okay, so this is all air present in there. Chest is separated from that. And chest drain is also in position here. Okay? Not correctly placed. The quadruple valve replacement, that is difficult to say that. What is this?
Bellissimo.
Huh?
No.
Some you can see this
Mitral valve
external
repair.
wires and all. Huh?
External wires can be seen.
External wires are there,
Yes.
and there is a ring here. What is this?
Valve.
Mitral valve replacement.
MBR.
Mitral valve repair.
Mitral valve replacement. Okay. This is right middle lobe consolidation.
Consolidation.
Pacemaker.
What is this?
Pacemaker.
Pacemaker presentation. The right double electrode.
External wires.
What are 2 and 3?
3 is valves, sir. Artificial valve.
Both are valves. Aortic and mitral valve. Both double valve replacement. MVR and AVR. They are only close to each other, you know. So that is how you check.
Dramatic.
Diaphragmatic hernia.
Hernia.
Very good.
Hernia.
And what is this?
Audiovented defect.
NG tube in the stomach. Okay, post-traumatic diaphragmatic hernia with a nasogastric tube which has been introduced and gone into the. So stomach is the one which has become the herniated structure. This is multiple rib fractures. You can see that.
Right side.
What is the yellow arrow pointing to?
Central line placement.
Central line.
And place.
Central line place.
Tubular.
What is the arrow pointing to? It is the right IJV catheter tip.
Right edge.
What is this case?
Mechanically ventilated.
Mechanical ventilation. Are the both areas of the lung evenly aerated?
No, sir. Left
No, sir.
decrease.
So it's an endobronchial intubation.
Endobronchial intubation. Right side.
Causing points the position of EP tube, which is not into, which is into the right side, causing collapse of the left. Okay. What is this?
ARDs.
Bilateral interstitial infiltrates.
Acute pulmonary edema, patient intubated and ventilated with IV catheter and EKG monitor.
Boot-shaped heart.
Tetralogy of Fallot. Boot-shaped heart.
Heart is like this.
Boot-shaped.
Boot-shaped.
Boot-shaped heart. So this is the allostetrology. This
Hyposcoliosis.
To the left side.
hyposcoliosis. For the findings in this. What does that black arrow show?
Wedge fracture. Wedge fracture of femurs.
Compression fracture of the vertebra. That is used of thoracolumbar spines with burst fracture of L2 body seen in the X-ray and CT. What is abnormal here?
Concussion.
Scalp
Scalp hematoma.
So this is the culprit here. All the inside intracranial structures are okay.
Intracerebral.
Intracerebral.
This area.
Left-sided stroke with edema and midline shift.
Okay,
Which
shift
shift?
of midline is
Midline shift.
also there.
EDH.
Extradural
hemorrhage.
Subdural hematoma and scalp hematoma is also there. See, this is the scalp hematoma. We should not miss that also. What is it?
Subdural hematoma with midline shift.
Midline shift.
Subdural with midline shift. Good.
Intraventricular hemorrhage.
Intraventricular.
Hydrocephalus.
Hydrocephalus.
Cross hydrocephalus showing dilated. What is shown here?
This is meningioma.
Tumor.
Tumor probably intracranial size blocking with the surrounding edema. Identify the pressure volume loop. Cardiac pressure volume loop.
Aortic stenosis.
Very good. Aortic stenosis.
Mitral stenosis.
Mitral stenosis.
Aortic stenosis. Very good. This is
Mitral regurgitation.
Mitral regurgitation.
Aortic
regurgitation.
Okay. This is next page. Not over. We go for some drugs.
Yes, sir.
Yes, sir.
Visible?
Sir.
So we'll start with the intravenous injection agents. Barbiturate thiopentol. What is thiopentol?
To sulfur
It's a thiobarbiturate.
The sulfur analog of oxybarbiturate pentobarbital. Okay? This is the sulfur analog. Of which barbituric acid formed?
urea plus malanoic acid.
Urea plus malanoic acid producing barbituric acid and water. How is it marketed and why?
It is a highly alkaline. It is a yellow anhydrous powder. And
500
consist
mg
of a few nitrogen. The
atmosphere
space is filled with nitrogen, sir.
Fantastic. So this is available as a 500 and 1001 gram vial as a pale yellow powder which has sodium carbonate 6% in nitrogen atmosphere. What does sodium carbonate do? This mixture of this powder. What is the role?
Buffer, sir.
Results in strong alkaline solution. That sodium disodium carbonate water produce sodium bicarbonate, sodium, and that is the one which gives the alkalinity. Why nitrogen is used instead of air?
It will precipitate the air.
CO2 in air can react with water and form carbonic acid, and nitrogen can cause less alkalinity, which will make it less water soluble. Okay. Does cypetone exhibit tautomerism?
Yes, sir. It exists as an enol form.
Yes, it has a water soluble enol form and less water soluble keto form.
Keto form.
What is its effect on respiration?
Double apnea, sir.
Causes double apnea, respiration during induction. Okay. Initially, there will be a suppression, then there will be one deep breath taken, and then there will be total apnea. Okay. So that's called double apnea. So the initial apnea lasts a few seconds, followed by a few breaths of normal breathing, then again followed by a prolonged apnea. Means need to provide respiratory assistance. What is the absolute contraindication for use of fat control?
Porphyria.
What are the other drugs which have to be avoided, or can also avoid all the intermediate halothane, lignocane, clonidine, metoclopramide, hyoscine, diclofenac, and tadalafil also should be avoided. Now coming to propofol, what is the chemical name of propofol?
2,6 diisopropyl.
Diisopropyl.
2,6-diisopropyl phenol. What preparations are available?
1% and 2%.
1%, 2%.
We have various volumes, 200 milligram in 20 ml, 1 gram in 100 ml. We have that 500 milligram in 50, three of different preparations. What is the pKa and what is the advantage of it?
11.
No,
pK is 11.
4.6.
Entirely unionized at a pH of 7.4, so it can enter the cell membrane easily. Why is it marketed as an emulsion?
Water.
Because it is not water soluble, it is made as an emulsion with a soybean and purified egg acetate. What is propofol infusion syndrome? Who are at the risk of this particular problem?
Children are at risk, sir. It occurs when
Lipid peroxidase enzyme.
given more than 72 hours continuously, it occurs.
More than 48
4 mg per
more
kg.
than 4 mg per
48
kg.
hours.
Common presenting features are new onset metabolic acidosis, cardiac dysfunction, rhabdomyolysis, renal failure, and hypertriglyceridemia. Risk factors for developing include severe head injuries, sepsis, high exogenous or endogenous catecholamine usage, and glucocorticoids, and high carbohydrate, high lipid intake, inborn errors of fatty oxidation. Of course, it is common in children. What is the chemical group vitamin
Pencyclidine.
belongs to?
Encyclidine.
Vitamin molecule, what is the name? It is called 2-chlorphenyl 2-methylamino cyclohexanol. Some examiners asked this particular chemical composition also. The vitamin is 2-O-chlorophenyl 3-methylamino chlorhexane. How is it presented as for clinical use? What are all the various preparations you have?
IV, IM, nasal.
No.
Vial,
Clear
marketed?
colorless solution.
clear color solution, 2 ml and 5
Preservative
ml.
free and with preservative. Vitamin hydrochloride available as 500 milligram 10 ml, 1000 milligram in 10 ml, 200 milligram in 20 ml, and also preservative free 50 milligram per ml, 2 ml ampoules are also available. Okay, so these are how it's marketed. Presented for clinical use means these are the various available strengths you have to say. What is the type of anesthesia produced by ketamine?
Dissociative anesthesia.
Dissociative anesthesia.
Called dissociative anesthesia, demonstrated on EEG by thalamocortical and limbic dissociation. What other mechanism of action does ketamine possess apart from its action on the NMDA receptor?
Opioid receptors.
Opioid kappa agonist.
Ketamine interacts with opioid, which is preference of mu and kappa receptors, and also antagonistic interaction at monoaminergic, muscarinic, and nicotinic receptors. And it has anticholinergic symptoms, tachycardia and bronchodilatation. and at high doses, local anesthetic properties. It may be through its ability to inhibit neuronal sodium. What precaution to be taken when ketamine is used intrathecally or epidurally?
Be preservative free.
Preservative free, sir.
Preservative free.
Preservative free. Very good. Coming to intermediate, what is the chemical nature of
Imidazole. Imidazole.
Imidazole group.
an imidazole derivative? How does intermediate affect steroid synthesis?
Inhibits
It
11 beta
suppresses
hydroxylase.
17 alpha hydroxylase and 11
adrenocortical.
beta hydroxylase.
So binds to P450 enzyme 11 beta hydroxylase, which is important for steroidogenesis. This effect is due to binding of a nitrogen atom intermediate in the gold ring to ion within the seal ring, the 11 beta hydroxylase enzyme, resulting in inhibition. So, what other imidazole derivative drugs are used?
Imidazole.
Metronidazole.
Fluindazole and midazolam also. What is the induction dose of intermediate?
0.3 to 0.6 mg.
0.3 milligram.
PM.
How is it metabolized in the body? It is very non-specific
But-
hepatic esterases and plasma cholinesterases hydrolyze intermediate to ethyl alcohol and carboxylic acid metabolite. What are the unwanted side effects of intermediate?
Myoclonus.
Myoclonic
Pain on injection,
Hydrocortical inhibition.
Pain on injection.
respiratory movements, cortical crisis, nausea and vomiting. Coming to analgesics, what is the difference between opiate and opioid?
Derived
Synthetic.
natural.
Hmm?
Opioid is derived. Opiate.
Opiate is all naturally occurring, like morphine, and opioid are synthetic substances which have affinity for opioid receptors. Describe the opioid receptors. What type of receptors are there?
Receptors.
There are G protein coupled receptors located throughout the CNS, more in nuclei of tractus solitarius, endothelial gray area, cerebral cortex, and thalamus. They are also located in spinal cord, biliary tract, and peripheral afferent nerve terminals. There are three main types: mu, kappa, and delta. They are named after using the first ligand that they found it up. How do opioids work?
AMP.
They act via G couple
Deep throat.
situated in the presynaptic area by exposing the voltage sensitive calcium channels, stimulation of potassium efflux, leading to hyperpolarization of cell membrane. What do you mean by hyperpolarization? We already discussed in the earlier classes. Increasing
Increase
negativity,
potassium.
cellular negativity. Normally it is minus 70 to minus 90. So if it becomes more negative, it's called hyperpolarization. So this mechanism where this hyperpolarization or increase in negativity is produced by acting on the voltage gated calcium channels and pushing the positively charged potassium outside. What other method is used by some drugs to produce hyperpolarization? Your drugs acting on the GABA receptors, how do they produce hyperpolarization?
Chloride.
But negative ions, if they are pushed inside the cell, that will also produce more negativity. Or you must push the positively charged ions outside. So either has to be done. Here it is positively charged potassium is pushed outside, so intracellular negativity increases. Whereas in GABA, outside chloride is pumped into the cell, make it more negative. Okay, so that is how the difference is there. Even though both are producing only hyperpolarization, from which the nerve membrane or the cell membrane cannot be stimulated. And they reduce the CAMP production reduce neuronal excitability and transmission. What is opioid-induced hyperalgesia?
Paradoxically,
Due to
Paradoxically,
central and
explain.
peripheral sensitization.
The state of nociceptive sensation caused by exposure to opioids, a paradoxical response whereby a patient receiving opioids for treatment may actually become more sensitive to certain pain stimuli. Morphine. What is the chemical nature of morphine?
Water soluble.
Huh?
Water soluble.
The phenanthrene derivative. Chemical structure or chemical nature means when you say
Derivative.
what are the preparations of morphine available? Available only as an injectable agent or available
oral
as a
for
tablet or
Tablet.
so
Oral
it is available as injectable,
intravenous.
available as tablet also. And it is also available as suppositories.
Yes, sir.
How does morphine cause muscle rigidity and constriction of pupil, meiosis?
Through mu and kappa agonist.
Muscle rigidity due to opioid receptor interaction with dopamine and GABA pathways, and meiosis is due to stimulation of Edinger-Westphal nucleus. Can morphine be used in renal failure?
No, sir.
No, sir.
No. Why?
accumulation of M6G metabolic
Morphine
fluid
6
will
glucuronide.
Via renal.
Morphine glucuronide, which is also very equally effective. Metabolite morphine and morphine 6 glucuronide, which is more potent, accumulates in renal failure due to decreased excretion. It's not safe. What is the oral dose of morphine?
4 to 6 mg.
5 to 20 mg portally. Where is it used most commonly? Oral morphine.
Pain, chronic pain.
Palliative pain. Okay? Palliative care. Final terminal cases of cancer which are not unable to get treatment. Palliative care, they use up to 80 to 100 milligram per day also. What is the parenteral dose?
0.2
0.2
mg per kg.
0.1 to 0. This is the intrathecal dose. What preparation to be used?
Preservative free and intrathecally 100 mics.
Pre-morphine dose 1 to 3 milligram. What are the features of morphine overdose?
Rhinuria, lacrimation.
Respiratory depression.
Respiratory depression.
Respiratory depression. That is the first thing I have to say. Respiratory rate will become so less, 6 to 8 breaths per minute. Okay, shallow or complete cessation of breathing, persistent sedation, unresponsiveness when taken or painful stimuli, vivid dreams or hallucination, delirium, muscle twitching, drop in blood pressure, pinpoint pupils, slow erratic pulse, bluish, purple or grayish discoloration of skin, vomiting. These are all the features. Coming to fentanyl, what is fentanyl?
Phenylpiperidine derivative.
Engineer, the synthetic phenylpiperidine derivative. Which salt of fentanyl is used?
Citrate.
Huh?
Fentanyl citrate.
Citrate. Citrate. Yeah, what are the routes of administration?
IV,
IV
IM,
and
epidural.
IM, patch,
Intrathecal.
Transdermal, oral,
Patch.
okay? This is the dermal durogesic patch. What is wooden chest syndrome? And why does it happen? Have you heard of this problem?
Yes, sir. Rapid
Yes,
and
sir.
high dose of
Ah.
fentanyl induction can cause
Wooden
chest
chest
rigidity.
syndrome is chest wall rigidity during administration of fentanyl, causing difficulty in ventilation. Okay? And it is skeletal muscle rigidity is bound to mu receptors the central nervous system, the activation of dopaminergic and GABA pathway. How is it managed? Supposing
Slow.
golden test syndrome happens, how
We
is
should
it
give
managed?
fentanyl slowly, sir, if you're giving high doses.
This opioid receptor antagonist naloxone
Naloxone.
or neuromuscular blocking agents such as chlorpronium, cessation of fentanyl infusion or supportive care. What is the dose of fentanyl for opioid-based anesthesia?
25 mics to 35 mics per kg, sir, IV.
50 to 100 miles per kg. So this is mainly done by cardiac anesthetics.
surgery.
For opioid-based cardiac anesthesia, it is 50 to 100 miles per kg. Why intrathecal fentanyl does not cause respiratory depression like morphine?
Lipid soluble.
Very good. Due to high lipid solubility, rapidly enters spinal cord from CSF and does not travel high up like morphine. Whereas morphine is water soluble. So it will go up and directly suppress the respiratory center. What is tramadol?
Right.
Synthetic opioids.
Bad.
The cyclohexanol derivative, it is a racemic mixture. How is it presented?
Tablet form.
What are the strengths?
50, 100.
Tablet as well as parenteral
Parenteral.
injection for IM use. What is the mechanism of action?
It is the weak opioid and weak opioid receptors and
New receptor agonist.
Against
also
at all opioid receptors, specifically new receptors, calm down of the locus coeruleus by inhibiting the norepinephrine release. These are the two mechanisms. What drugs interact with tramadol? Drug which you are using every day, isn't it? It can react with tricyclic antidepressants, selective serotonin reuptake. That's mostly all drugs used by psychiatrists
Psychiatrist.
and cause seizures. So if the patient is taking these two groups of drugs, we have to be careful. What is the contraindication for its use?
Renal failure.
Not to be used in patients suffering from epilepsy. How is tramadol metabolized?
Liver.
The two main pathways, O demethylation and N demethylation, both catalyzed by liver enzymes. How does tramadol help in controlling post-spinal cigarette?
It raises the threshold of hypothalamic threshold.
By inhibiting reuptake of norepinephrine and serotonin and activating the descending spinal pathways.
The person you have called is speaking to someone else.
Paracetamol.
You can wait for call.
What is the composition of paracetamol infusion?
Water for injection. Glucose.
So waterfall injection now, why should I ask it as a question? Okay. Each vial 1000 milligram in 100 ml. The ingredients are cysteine hydrochloride monohydrate, disodium phosphate dihydrate, hydrochloric acid, sodium hydroxide, mannitol, water for injection. Okay. Every day, I think all of you are using this right, left, and center. But you must know the composition. How are prostaglandins synthesized?
From arachidonic acid, sir.
Arachidonic acid. So membrane phospholipids acting on systolic phospholipase A2, arachidonic acid, reducing prostaglandin B2 by cyclooxygenase. Can paracetamol be called as a non-steroidal anti-inflammatory drug?
No, sir.
No, sir.
Is not considered an because little anti-inflammatory activity It treats pain mainly by blocking
COX2.
COX2 mostly in the central nervous system. What happens in paracetamol overdose?
Acute hepatic toxicity, sir.
How does it produce?
There is a metabolite
Betadine
called
stores.
NAPKI, N-acetyl benzoamine. It accumulates and causes
Formation of NAPQA, which is a acetaminophen conjugation to glucuronide moiety, which is non-toxic, can conjugate also with sulfate, which is also non-toxic. But when it combines with N-acetyl parabenzoyl, then it has to be neutralized by glutathione. So the glutathione stores will be exhausted. And that is the one how it produces the cysteine and method bispecific conjugates of the call. What are the side effects of NSAIDs and how are they caused?
acute tubular injury, peptic ulcer disease,
Bleeding.
bleeding.
How are they caused?
Bleeding is caused due to qualitative defects in platelet.
All because of prostaglandin blockage. Main side effects are renal failure, aggravation of gastric ulcer, aggravation of asthmatic attacks, and blocking of prostaglandin production results in renal damage by causing renal inner medullary ischemia and interstitial nephritis. The stomach, the mucus production is blocked by the same mechanism, resulting in exposure to the acid in stomach leading to ulceration. Blockade of thromboxane leads to bleeding, and an unopposed action of leukotrienes causes aggravation of asthma. So these four important side effects is mentioned: renal damage, gastric ulcer provocation, lesser action of platelets, and aggravation of asthma. So these are all the preparations that we have, which we commonly use. How are NSAIDs classified?
Selective and non-selective COX inhibitors.
So there is a citation by Tripathi, non-selective COX inhibitor, preferential COX2 inhibitor, selective COX2, inhibition with 4 anti-inflammatory. This is how the classification is done. These are all the various coming to local anesthetic drugs. How are local anesthetic drugs classified?
Amides and esters.
Esters and amides. Examples are
It's steroids and
how is lidocaine metabolized?
Liver, sir.
It's metabolized to xylidine.
Xylidine, yes. Metabolic pathway, monoethyl glycine xylidide, followed by hydrolysis to xylidine ultimately. And 80% activity of the lidocaine has prolonged elimination of time. Hepatic diseases or decreased hepatic flow increases the duration. So it is mainly metabolized in the liver. How does prilocaine cause methemoglobinemia? Is because metabolized to orthotoluidine. Orthotoluidine can cause methemoglobinemia. When dose of prilocaine is more than 600 milligrams, sufficient methemoglobin may be present to cause the patient to appear cyanotic and oxygen carrying capacity is decreased. What is the difference between lignocaine and mepivacaine? Mepivacaine has pharmacological properties similar to lignocaine, although the duration of action is somewhat longer. Whereas lignocaine, mepivacaine lacks the vasodilatory effect of lignocaine. In alternative selection, an addition of epinephrine to lignocaine is not recommended. That is the main difference. Longer duration, no vasodilatory effect. How is bupivacaine metabolized? Metabolism includes aromatic hydroxylation and dealkylation, amide hydrolysis, and conjugation. 4 pathways are there. The urinary excretion of bupivacaine and its dealkylation account for more than 40%. How is opivacaine metabolized? Metabolized by 5-polyethylene. And a very small fraction of opivacaine is excreted and killed. What are the guidelines for last by AAGBA? It's local anesthetic systemic toxicity. What are the guidelines by Association of Anesthetics of Great Britain and Ireland?
You should stop the offending agent, sir.
Call for help.
Recognition first, immediate management, treatment, and follow-up. So these are the 4 steps that have been done. And what is the toxicity ratio of local anesthetic agents?
Serious by CNS ratio, bupivacaine 3,
3,
lignocaine
7.
It is the ratio between plasma level needed to
Level.
produce CBS effects divided by plasma level needed for CNS effect. That is the ratio. That is how it is defined. And the value for that for lignocaine is 7, bupivacaine 3, bupivacaine 5. What are the new methods to prolong the duration of action of local anesthetic drugs?
Liposomal formulations.
Very good. So liposomal encapsulation, biodegradable polymer microspheres, and site 1 sodium channel blocker, which is called neosaxitoxin. So these are the neosaxitoxin and similar neurotoxins have low affinity for cardiac sodium channels relative to their affinity for sodium lysosomes. What is lipid rescue for last?
Lipid emulsion.
Using lipid emulsion to create a reservoir
Solid.
so that it goes out of the systemic circulation into the plasma, from the receptors into the plasma.
For which particular drug you use this?
Bupivacaine, sir.
Racemic bupivacaine toxicity. Yeah, give lipid emulsion 20% and immediately give IV bolus 0.5 ml per kg over 1 minute and start an IV infusion at 15 ml per kg per hour. Maximum of 2 repeat 1 ml boluses may be given at least 5 minutes apart if the patient has cardiovascular instability or in cardiac arrest. And increase the rate to 30 ml per kg per hour if hemodynamic stability is not restored after 5 minutes. The infusion with hemodynamic stability is restored up to the maximum dose. Do not exceed a maximum cumulative dose of 12 ml per kg. Base dose on lean body weight in extremely obese patients. So this is highlighted. Coming to sympathomimetic, what is the structure of sympathomimetic drug? We call them as catecholamines. Catecholamine, the monoamine neurotransmitter, an organ compound. The catechol benzene ring with 2 hydroxyl side groups to each other and a side chain amine. So this is the benzene ring with 2 hydroxyl groups. So this is called the catechol nucleus. And if you have that, this is the hydroxyl group at C3 and C4 of benzene. Now if you add an amine to the side, this becomes dopamine. So amine group added at C1 position in addition to the hydroxyl in C3 and C4. Now you add another hydroxyl, it becomes noradrenaline. So another hydroxyl attached to the amine side chain. Now you attach a methyl group, then it becomes adrenaline. Methyl group added to the amine side chain, it becomes adrenaline. So this is how the of transformation happens from the basic catechol to adrenal formation. How are sympathomimetics classified? Naturally occurring like adrenaline or adrenaline and dopamine, synthetic drugs like dobutamine, dopexamine, isoprenylate. They also have catechol ring. Other inotropic agents, aminophylline, milrinone, levosimendan, calcium, and thyroxine. This is adrenaline bitartrate. This is adrenaline hydrochloride. What is the difference between these two? There are two different salts of adrenaline. One is bitartrate. What is the difference between these two preparations?
The bitartrate form is not active, sir.
Bitartrate more for
It's not active.
not active. Then why do they market it? Adrenaline bitartrate is a synthetic preparation, whereas hydrochloride is a naturally occurring. Okay. What are the various uses of adrenaline in clinical practice?
For
Anaphylaxis,
advanced cardiac life support.
Anaphylaxis.
anaphylaxis, bronchospasm,
Use in cardiac arrest in doses of 1 milligram every 2 to 3 minutes for adults and 10 minutes per kg for pediatrics. Very good. Then in anaphylaxis,
Anaphylaxis.
100 mics or 0.3 to 0.5. As an inotrope in ICU, dose of 0.01 0.3 mics per kg. Then the other is
spinal,
we use it for vasoconstriction
yes sir,
in surgery.
yes sir,
We use
yes
it
sir,
as a nebulizer in acute asthma.
Bronchodilation.
Added to local anesthetics to prolong the action. These are all the. What is the salt of noradrenaline?
Bitartrate.
What type of infusion set to be used for inotrope administration? Drops per minute. So you have to use what is called the micro drip
Infusion
set.
pump.
Can give 50 beats per minute. Of course, with the advent of your infusion pumps and syringes, all these things are becoming bigger. Dopamine and dobutamine. What are the differences? One is dopamine is natural catecholamine, precursor to noradrenaline, whereas dobutamine is a synthetic catecholamine. Mechanism: adrenergic, dopaminergic, whereas dobutamine is purely adrenergic. Beta 1 more than beta 2 more than alpha. And effect on BP, sustained. 4. Effect on PCWP, not favorable. Arrhythmia, more with dopamine, more with dopamine also. Inotropic action, more consistent with dopamine. Rather than clinical uses, it can be used in cardiac failure, ischemic LVS. So, ischemic heart disease, acute pulmonary syndrome, dobutamine is more preferred than dopamine. How are these drugs marketed? These two drugs. $250 milligram, 20 ml. And the Dobustat also available like this. And the dobutamine injection is available as 50 milligram in 5 ml ampule. And dopamine is available as 200 milligram in 5 ml. Digoxin. What are the indications for use of the following preparations of digoxin? That is digoxin injection, 500 micron into ml. Digoxin tablet, 0.25 milligrams. When will you use the injection? When will you use the tablet?
Tablet for maintenance, sir. For cardiac failure.
Cardiac failure.
Tablet for slow digitalization. Okay. Whereas parenteral injection is for rapid digitalization. So injection for rapid digitalization and the tablet for slow digitalization. What is the mechanism of action of digoxin?
Inhibit sodium potassium ATPase.
Potassium ATPase.
Pump at calcium sodium exchange.
Calcium sodium exchanger.
So this is the mechanism. Sodium potassium ATPase pump inhibition causing increased calcium and increased force, and vagal stimulation reducing AV conduction and reduces the rate. So it enhances the contractility and also brings down the heart rate, which helps, and that is the reason it was extensively used in the earlier days in cardiac failure because of these two items. What is isoprenaline?
Pure beta agonist.
The non-selective beta adrenoreceptor agonist, that is isopropylamine, analog of epinephrine. This is the structural nature. What are the indications and contraindications for its use? Used in bradycardia with excess dose of beta blocker, heart block, and rarely for asthma. And it should be not used in people with tachyarrhythmias or tachycardia, heart block caused by digital poisoning, or ventricular arrhythmias which require inoperability, or with angina. What is the half-life of isoprenaline?
Few minutes, sir.
Half-life is approximately 2 minutes. What is the dose? Bolus intravenous, dilute 1 ml, that is 0.2 milligram in 9 ml of sodium chloride injection, 5% dose, and give 0.02 milligram to 0.06 milligram IV, and 0.01 to 0.02 to 10 ml diluted solution. And what is dopexamine? Already we have seen it is a synthetic analog of dopamine. How is it presented? 50 milligram in 5 ml. What is the mechanism of action? All of them should act on adrenergic receptors, isn't it? Stimulated beta 2 adrenoreceptors and dopamine and D1 receptors affect on alpha receptors. What are its uses? Used to improve cardiac output and mesenteric perfusion. What is the dose? 0.5 to 0.6 mics per kg per minute. What is the half-life? It's also 7 minutes. What are the potentially hazardous interactions with other drugs? Antidepressant, risk of hypertensive crisis. Beta blockers, risk of severe hypertension. Hypomimetics, effects of adrenaline and noradrenaline possibly. Phenylephrine, the hydrochloride, of course, we are using it routinely. Direct acting symptomatic, medically related to adrenaline nicotine, potent vasoconstrictor. Medication is the optimal choice for raising mean arterial pressure by inducing vasoconstrictor in both veins and arteries, enhancing cardiac preload without exerting significant effect on cardiac myocytes. Over-the-counter medication in ophthalmic formulations to facilitate mydriasis and vasoconstriction of conjunctival blood vessels. Furthermore, this medication is administered intranasally to treat uncomplicated nasal congestion, obviously additive to topical hemorrhoid medications also. It can be used on topical, IV, intranasal, ophthalmic, and rectal. Dose is 0.1 to 1.5 microgram per kg. What is adenosine?
Purine.
Purine nucleoside.
The naturally occurring purine nucleoside. And it's one of the 4 nucleosides or building blocks of DNA and RNA, which are essential for life. What are the other 3?
Cytosine.
DNA formation. What is the difference between a nucleoside and a nucleotide?
With the ribose and the molecule, it is called a nucleotide. So
Ribose is there.
Phosphate.
Phosphate. The base sugar plus phosphate is a nucleotide. Base plus sugar only is a nucleoside. So if the phosphate group is attached, then it becomes nucleotide. Otherwise, it is a nucleoside. What are its uses? Adenosine.
Mainly for PSVT and SVT, sir.
Supraventricular
Treatment of SVT in the nuclear stress test as an adjunct to thallium also. What is its mechanism of action?
It blocks the ATB receptors.
Is with potassium reflex decreasing calcium reflex. It hyperpolarizes cardiac cells. And clinical application, paroxysmal supraventricular tachycardia. You can give rapid IV injection. The side effects are flushing, chest pain, and dyspnea. And what is the half-life and how it is metabolized?
It is too much.
Half-life is less than 10 seconds.
Plasma.
Rapidly deaminated in plasma by or taken up by RBCs. Esmolol. What is esmolol?
The cardioselective beta blocker.
Beta blocker.
Not acting. The cardioselective
Cardioselective beta
What
blocker.
are its uses?
To attenuate the laryngoscopic response.
Blunting the hemodynamic response to laryngoscopy and intubation.
Hypertension.
Systolic atrial fibrillation of flutters to control ventricular rate. To reduce heart rate and BP during and after cardiac surgery, beating heart CABG. Terminate supraventricular tachycardia. Why is it named esmolol? What is its relevance to its metabolism?
it's metabolized by plasma non-specific esterase.
Structure reflected, esmolol is ester methyl. And esmolol is rapidly metabolized by hydrolysis of ester linkage, chiefly by esterases in the cytosol of red blood cell, and not by plasma cholinesterase or red cell membrane cell cholinesterase. And what is the dose?
Bolus dose 500 micrograms per
Loading dose 0.5 milligram per kg, given followed by 0.05 to 0.2 kg.
amiodarone class 3
Class 3
antiarrhythmic
antiarrhythmic.
drugs in 1 billion.
Benzofuran derivative. Mechanism of action.
It mainly potassium channel blocker, but it blocks all sodium channel and calcium channel.
Blocks potassium, blocks sodium, calcium channels with the receptors, depresses SA node, prolongs action potential duration, prolongs early repolarization phase and repolarization. What are its uses?
To restore the rhythm AF and ACLS according to the ACLS 300 mg.
Treatment of SVT, ventricular tachycardia, WTW syndrome. What is the dose?
In routine dose 150 mg per kg
Bolus.
for 10 minutes, sir.
Loading dose 5 milligram per kg over 1 hour, followed by 15 milligram per kg for 24 hours. Side effects?
Hypotension.
Hmm.
Long term, it
Long-term and
Pulmonary
long-term.
fibrosis, pulmonary fibrosis, hepatic fibrosis, and
Thyroid
hyper and hyperthyroidism.
So you can remember the side effects by this: thyroid hypoactivity, photosensitivity, peripheral neuropathy, lung fibrosis, liver damage, cardiac depression, corneal microdeposits. So, peripheral parts possession of this interstitial lung fibrosis, one of the major complications of long-term use. What is the mechanism of action of NT?
Vasodilators, sir.
cyclic CGMP channels.
CGMP.
So it gets converted to nitric oxide,
Nitric oxide.
activation of coronary soluble eminyl cyclase, increase coronary cyclic GMP level, which act on the plasminoid BK channel. Also goes through so many calcium, potassium, ATPs. It's extensive. What are the effects on CVS?
Hypotension and tachycardia, sir.
Mainly a vasodilator causes reduction in preload, decreases wall tension and oxygen demand, increases coronary blood flow. What is the cause of tolerance to nitrates? Due to depletion of sulfhydryl group within the vascular smooth muscles. Okay? So they don't become responsive. How can tolerance be prevented?
Drug-free.
Drug-free
Interval. For
2
12 to 14
hours
hours.
of drug-free period, the infusion of acetylcysteine, which provides sulfhydryl group, is helpful. What drugs causing neuromuscular blockade classified?
Depolarizing and non-depolarizing.
So there are 4 classifications. Preventing acetylcholine synthesis, which is called vegetarianism. Prevent acetylcholine release, magnesium, aminoglycoside, and botulinum. Depleting acetylcholine stores, as in tetanus, and blocking acetylcholine receptors, like neuromuscular blocking drugs, which are classified as depolarizing and non-depolarizing. So there are 4 mechanisms whereby neuromuscular blockade can be done. So just saying depolarizing and non-depolarizing is only one part of the answer. The other things are all different mechanisms. What are the side effects of succinylcholine?
Bradycardia.
Hyperkalemia.
Intraocular pressure, intragastric pressure, muscle
Raise IOP, ICPI.
anaphylaxis.
And increase the potassium value 0.5 milliequivalent.
So there are 8 side effects. Myalgia, which is the most commonest, cardiac arrhythmia, hyperkalemia, increase in IOP, increase in intragastric pressure, anaphylaxis, polycythemia, pneumonia. What are the contraindications for use of succinylcholine?
History of malignant hyperthermia.
Patient.
Malignant hyperthermia.
The burns depending on the duration, hyperkalemia, and renal.
Open globe injury.
Hyperkalemic states like CKD, severe muscle trauma, history of malignant hyperthermia or polynephrine in the family, burns, spinal cord injuries with paralysis of long duration. How many stereoisomers are there in atracurium and why?
Two stereoisomers.
There are 10 stereoisomers in atracurium. Because of this, it has 4 chiral molecules. What is Hoffman degradation and what are the metabolic products of atracurium by this route?
Laudanum.
Spontaneous non-enzymatic degradation at
depend on
physiological
the
pH
pH
and
and temperature.
What is the metabolic product?
Laudanum and acrylate.
Spontaneous degradation due to variations in body pH and temperature is called Hoffman degradation. And laudanum and quaternary monoacrylate. These are the two byproducts. What is the other route of elimination and what are the metabolites?
Hydrolysis.
Plasma 45% of the
Ester hydrolysis.
hydrolysis.
Ester hydrolysis. The non-specific species into laudanum, quaternary alcohol and quaternary acid. So these are the between cis atracurium and atracurium, which has faster onset of action and why?
Cis-atracurium is the faster onset of action.
Why?
So more potency.
This is because of higher dosage is required. Atracurium has faster onset of action than cis because of the higher dose of 0.5 milligram that will be required.
Yes,
Even though that potency wise, cis-atracurium is more potent. That will be only 0.015. But the onset is faster with atracurium. Anticholinesterase. Classify the types of anticholinesterase.
Plasma.
Competitive hydrophonium those forming carbamylated enzyme complex, neostigmine and pyridostigmine, the irreversible activating agent, like organophosphorus compound. What are the types of acetylcholine receptors? Why are they named like that? What category they belong
Nicotinic and muscarinic.
to? Nicotinic and muscarinic. Why are they named like that?
Muscarin and nicotine were initially used to
Ligands. Okay, very good. They were named after the ligand which were first found to bind with them, nicotine and muscarine, also known as mushroom poison. Nicotinic receptor is a ligand-gated ion channel receptor, and muscarinic is a G protein coupled. What are the uses of anticholinesterase?
reversal of non
Reversal and antipyretic snake bite venoms.
Used to reverse the residual effects of neuromuscular blocking drug, used in the treatment of myasthenia gravis also. Define vomiting.
It is a forceful expulsion of the content from stomach to the mouth.
The retching followed by expulsion of gastric content. Name the different input vomiting centers and the receptors and their location.
Labyrinth, acetylcholine,
serotonin,
from gut to serotonin,
Dopamine.
The inputs are
Chemotrigism.
anxiety, raised intracranial pressure, gastric stasis, radiation, colitis, chemotherapy, drugs like hypercalcemia, vestibular neuritis. The pathways are cerebral cortex, receptors are GABA and H1 receptor, histamine 1 receptor, peripheral GI tract, dihydroxytryptamine D2, liver and GI tract. Then chemotherapy trigger zone, receptors B2, dihydroxytryptamine, neurokinin 1, vestibular input from acetylcholine and then H1. So all of them stimulate the vomiting center in the medulla, acting through all the. How does dexamethasone help in vomiting? What are the mechanisms? Nowadays we are routinely using dexamethasone, isn't it? Along with ondansetron.
yes, sir.
What is the mechanism of dexamethasone helping to reduce vomiting? Anti-inflammatory effects, direct central action on the solitary tract nucleus, interaction with the neurotransmitter serotonin and receptor proteins like tachyphyllin, neurokinin 1, 2, and alpha adrenaline, maintaining the normal physiological function of organs and systems, and regulation of hypothalamic pituitary adrenal axis. So there are so many theories because nobody knows the exact mechanism how it acts. So all these theories have been put forth. And also reducing pain with concomitant use of opioid, which in turn reduces opioid release. How metoclopramide helps in vomiting?
Dopamine antagonist.
Dopamine antagonist
Open
receptors in the
appetite.
chemotrigger.
So blocks the central dopamine receptors in the chemoreceptor trigger zone. Also acts on the peripheral dopamine receptors to cause prokinetic effect on the stomach. Augments peripheral cholinergic receptors. Blocks pyrotrophy dopamine receptors also. So there are four mechanisms: central, peripheral, and in peripheral you have dopamine receptor action in the stomach and also on the cholinergic and serotonin receptor. What is shown here?
Midazolam injection vial.
Midazolam. Midazolam, benzodiazepine group of drugs. What are its actions and how are they caused?
GABA A receptor.
Increased chloride act.
Hypnotic and anxiolytic effects. It's caused by GABA A and GABA B interaction. How is it presented?
Isomerase.
Is it available only as a vial or is it available as an ampule?
Oral midazolam also available, sir.
This is 5 milligram
Syrup?
in 5 ml vial. Is it
Yes,
available in
ampule.
any
It
other
is available as ampule. One
ampule? 1
1
ml
mg.
containing 5
1 mg.
milligram. Okay, it's presented as a clear colorless solution. What is the pH?
So water soluble less than 4.6, sir, and if it enters into the bloodstream, it will 7.6.
What is the peculiar structure of midazolam?
Tautomerism.
Structure dependent on the surrounding pH. At pH 3, it is a diazepine ring structure. It is open, making it a ionized molecule and water soluble. At more than pH 4, the ring structure closes, making it unionized and lipid soluble. So at physiological pH, 89% is unionized, resulting in faster onset of nectar. So this is the two forms: closed ring form and open ring form. So it can change between these two. And this is called the tautomerism or
Tautomerism.
dynamic isomerism. Other name for the tautomerism is dynamic isomerism. How does this drug differ from midazolam?
Longer
Long
acting.
acting.
More rapid onset. Midazolam has more rapid onset, greater anesthesia, 2 to 3 times potent, twice the affinity for benzodiazepine receptor, greater decrease in blood pressure and heart rate. This systemic vascular resistance is maintained, less post-procedural sedation, same time to complete. How is diazepam overdose treated? What is the antidote for it?
Flumazenil, sir.
Flumazenil.
What is the mainly supportive antidote is flumazenil, starting dose 0.1 milligram bolus up to 0.3 to 0.6 IV depending on consumption of diazepam. What is the adverse reaction to flumazenil?
Anaphylaxis.
Anaphylaxis. Seizure, can cause seizure. What are the uses of phenytoin?
Anti-epileptic.
Anti-seizure
And
and
Epileptic.
Treatment of grand
One
mal
week.
seizures, trigeminal neuralgia, treatment of ventricular arrhythmias caused by tricyclic overdose. What is the mechanism of action?
Sodium channel blocker, sir.
The sodium channel blocker. It can also reduce calcium entry into neurons. Okay,
1B, sir.
what class?
1B, sir.
Very good. Yeah. And it all.
Osmotic diuretic.
Osmotic diuretic. What about users?
For
Cerebral
anti-edema,
edema.
increased ICP.
Reduce ICP during neurosurgical procedures.
And
Okay.
IOP.
Reduce IOP during ophthalmic. Very good. Then
For renal
Renal
protection.
protection.
preserve renal function in jaundice patients. To promote diuresis in donor during renal transplant. Promote renal function during aortic surgery after clamp release. What is the half-life of mannitol? About 100 minutes. Lasix. What is the mode of action of Lasix?
Loop diuretic.
Loop diuretic.
Loop diuretic. What exactly does it do?
It blocks sodium
The
potassium.
reabsorption of sodium chloride in thick ascending only some extent in the early part of crystal communication. This action impairs countercurrent multiplex system to reduce metabolic hypertonicity, causing reduced reabsorption. Why is it called Lasix?
Lasts for 6 hours.
Action lasts for 6 hours. What is the purpose of IV fluid administration?
To correct the dehydration.
Maintain tissue perfusion and electrolyte concentration. This is the composition of various IV fluids commonly used will be asked in the exam. So these are all the various IV we use. Their composition. What does osmolality and tonicity mean? Are they both same or different? We say isoosmolar and isotonic. Are they both same or different?
No, sir. Osmolality refers to the number of moles per kg of the solution. Tonicity compares a solution to the plasma's osmolality.
Okay, more correctly can say like that. Osmolality is a measure of the osmotic pressure of a given solution. Whereas tonicity is a measure of osmotic pressure gradient between two solutions separated by a permeable membrane. So tonicity is a comparison of osmotic pressure, whereas osmolality is the osmotic pressure value of a given solution. Right? That is how it is to be. How are IV fluids classified?
Crystalloids and colloids.
Crystalloids.
Crystalloids and colloids. Classified on two categories based on the content as colloids and crystalloids. Any other classification?
Based on
Isotonic.
Based on osmolality and tonicity, it can be hyperosmolar, isoosmolar, or hypoosmolar. Then, any other classification? How much fluid will be retained in the intravascular compartment when 1 liter of normal saline and 1 liter of 5% dextrose? I think I have given this calculation earlier. So normal saline is isotonic, so it will distribute the extracellular compartment, the intravascular compartment as a ratio of 10%. So 250 ml will be retained. Whereas dextrose will be immediately metabolized and it will leave only 1000 ml of water, which is hypotonic. Out of which it will go out 2/3 into intracellular and 1/3 will remain extracellular. Out of which only 25% will be there, so only 84 ml will remain in intravascular. Okay, so that is a pretty short separation of all the drug flows. Shall we stop here? Other machines and ECG, I think it's time permits, we can discuss in the next class.
Yes, sir.
Yes, sir.
Good.
No,
Any doubt?
sir, I would like to. No, sir, no doubt, sir. I would like to thank you for all your support because I passed the theory exams. So
Oh,
you have
congratulations.
helped a lot.
Thank you very much.
Yes, sir.
Thank you. I'm very
Your
happy
videos
that
helped a lot.
this gives a lot of satisfaction to a teacher when they
Yes,
know
sir.
that all the students are passing. And of course, your efforts are also there. And I am only trying to guide you how to present your answers. And I'm very happy that
No,
all
sir,
of you are.
lots of motivation because sitting for so long at you are giving such an inspiration for you are taking the classes for so long hours. Sometimes we are not being able to keep the concentration to hear it so long.
So you want me to cut down the hours and make it shorter?
Sir, actually everyone wants that, but it helps a lot for the time which you continue.
Thank you.
Yes, sir.
All the best for your practical exams,
Yes,
and
Yes, sir.
I hope you will all make the record of passing like your theory. All of you should get through. I pray to God also for that, and also wish you all good success. In case we don't have the next class time, then you will let me wish you all good luck for your practical exams also.
Thank you, sir.
Thank you, sir.
Okay, sir.
Thank you very much, sir. Thank you, sir. Thank you, students. We'll sign
Thank
off
you.
today's.
Yes, sir.
Thank
Thank you
you,
very
sir.
much.
Thank you.
Good night, sir.
Good night.